Good morning, everyone, and welcome to the House Committee on Health, Human Services, and Elderly Affairs. As noticed, we have several bills for consideration and public hearing today, as well as an executive session this afternoon. Before we get to those, I ask you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. First bill to be heard today is HB 1317, and I will recognize the prime sponsor, Representative Heath Howard from Stratford District 4.
Thank you, Mr. Chair. For the record, my name is Representative Heath Howard. I represent the communities of Stratford and Barrington in Stratford District 4. I come to you in support of HB 1317, a vital piece of legislation designed to safeguard the most personal information of our citizens. We live in an era where data is often treated as a commodity, but we must remember that for the people of New Hampshire, privacy is not just a preference. It's a value rooted in our love for personal liberty and limited government. Our state constitution explicitly recognizes the right to privacy in Part 1, Article 2B, the right to privacy. And today, we have the opportunity to reinforce that right. This bill ensures that state agencies, political subdivisions, and their contractors cannot simply collect, maintain, or disclose personally identifiable data, medical information, disability, or mental health data to third parties without a specific or justified reason. This bill is a necessary shield against government overreach. Currently, individuals living with medical conditions, disabilities, or mental health needs face stigma or discrimination if their personal data is improperly handled. HB 1317 sets a clear standard. The default must be privacy. Under this law, your personal health care information remains yours unless you or your legal representative provide informed written consent. Disclosure is expressly required by state law or court order, or it is strictly necessary to coordinate your health care and benefits. Even when disclosure is required, this legislation mandates that agencies disclose only the minimum data necessary and utilize de-identified or anonymized data whenever practicable. This ensures that the Attorney General has the clear authority to enforce these protections, holding those who violate them accountable through civil penalties and corrective action. The policy of our state should be clear. Granite staters shall not have their private healthcare information disclosed by the state government unless required by state law or upon their consent. I urge you to join me in supporting HB 1317 to protect our most vulnerable neighbors and ensure our state government respects the boundaries of our citizens' private lives. Thank you, and I'm open to any questions.
Thank you, Representative Mazur.
Hello, thank you for taking my question. So last week we heard a hearing on HB 1316, which was restricting the collection and disclosure of autism-related data by state agencies. How is this different?
This goes beyond just autism. It covers all different aspects of healthcare privacy data. So we're talking about not just autism-related information, but per se, if somebody had PTSD, that wouldn't be covered under 1316, but it would be under 1317.
Thank you.
Anyone else? Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. I will confess that, excuse me, on page 2, they're listing Roman 1 through 7 standards of information processing that are currently in place. And as I said, I did not read all of them. My question is, we're trying to, in what way do we develop further policy in this area versus enforcement of what we already have? Can you identify for me a problem currently that this would address that is not addressed with all of the 7 which you want to leave in place? So,
Yeah.
rather than inventing something new, let's enforce what we have.
So there's actually an amendment that I worked with DHHS on to address that, because they suggested that those be removed in terms of reference to current language, and it is something that is no longer in the amended version if that's something that the committee takes up. I would say that this does protect people beyond what the federal government has outlined, and it ensures that we have state level protections.
Mrs. Grant, do you have that amendment? Is that what you have there?
Yeah, I mean, if it's okay to hand it out.
Absolutely. If you want to pass that out, that'd be great.
Yeah. Oh, thank you. I appreciate that. Thank you.
Oh, sure. Sorry.
Again, back to can you identify a particular problem that this bill, even with the amendment, that wouldn't be addressed already?
Yeah, so this is, again, a proactive piece of legislation because, again, we are in a position where we are seeing programs that AI has, taken access to information. And we do need to think about how we can limit that, because we shouldn't be necessarily just giving away people's personal healthcare information. And there is a lot of data being taken in by a number of these software programs. So that is one area where I do think that we need to have additional protections and be proactive on making sure that people have control over what data they provide access to.
Anyone else? Oh, Representative Drew.
Thank you, Mr. Chair. I've interacted with a number of the different AI companies. They always explicitly require your consent for information that you give them. So how would this stop that from happening?
So it is something where we do see oftentimes these AI companies buying data in bulk, and it's the question of if there is an opportunity to purchase some of this data through the state or a third party. Let's say that there's an agency that we're contracting with, which is covered in this legislation. If that agency said, sold that data to an AI corporation, technically that would be a legal sale, but this is something where we can put that protection in place proactively. Because in terms of the data, if somebody gives that to a third party, that is technically the ownership of that third party. So it's something where we can there is a way to get around that.
Follow up.
So are you saying that I have given consent for my data to be given to a company, and that this bill would prevent that company, the data that I consented to give them, would prevent that company from then selling it to a third party?
No, that's not what I'm saying. I'm saying that in terms of the contract that this also covers, because it's not just political subdivisions, it's not just government agencies, but it's also corporations that we contract with, and we do give these contracted companies data, and that is something that we should put a little bit more tighter regulation on, is what I'm saying.
Representative Kesselring and then Representative Weber.
Thank you, Mr. Chair, and I will probably have 2 parts to this, just to know. Thank you for taking the question. I guess I'm not looking at the amendment completely yet. Looking at the original text of the bill, I see that it was outlined that we wouldn't be affecting a disability, different programs, and things like that. But there is a concern that I have about other programs like Medicaid, some of the other VA stuff that you have. Those are different contractors that actually have to communicate with those departments. It looks to me like the language would affect those departments and those federal funds, or even slow those federal funds from being dispersed. Could you add to that?
In my personal belief, that is not going to be a concern, because this does allow those contracted companies to disclose that data in terms of a necessary agreement with the federal government. So that is something where I don't necessarily think that there are going to be the hiccups. I think this is something that, again, DHHS has also, worked on in terms of clearing their concerns. And this was not something that was raised in terms of the potential slowing of providing care.
Follow up.
The follow up to that. So on the reporting requirements specifically, with that, it doesn't, obviously the state agencies, when you outline the contractor, do we need to specify in HHS, I guess, what those contractors' roles could be? Because I know that we have two levels of contractors, let's call it. We have the federal and we have the state that do different things for different programs. So I just asking that question about it.
Yeah, that's something that I'd have to get back to you on, if that's okay.
Representative Warburton.
Thank you, Mr. Chair, and thank you for taking my question. Just so I'm clear, I'm now looking at the amendment. Am I right in thinking that the amendment simply takes out all of the things that are on page 2 of the original bill, which are the health, Board of HIPAA, and all the other list of things? And if that's what it does, why does taking those out make this better?
Yeah.
Because and I guess my other question is, if we left them in, would we not need to put all the other sorts of things mentioned by Representative Kesselring and others in?
Yeah, so thank you for the question. This amendment also does a little bit beyond just that. There were some concerns about some of the language used in terms of using the terminology required. So I don't have it circled on this document, unfortunately. But there is a line where it changes required to approved in a couple places, for instance, and I can send over the document of all the changes that were made.
That would be very helpful.
Yeah,
Thank
of
you.
course. But yeah, in terms of going back to the elimination of the list on page 2, that I think was partially because of redundancy.
Okay, thank you.
Anyone else? Okay, thank you.
All right, thank you.
Also signed up to speak is Vanessa Blaze.
Thank you, Mr. Chair, members of the committee. My name is Vanessa Blaze, and I serve as the Director of Policy and Planning for the New Hampshire Council on Developmental Disabilities. And I am here in support of HB 1317. The New Hampshire Council on Developmental Disabilities is a nonpartisan, federally funded state agency that is mandated through the DD Act. And 60% of our council members are either individuals with intellectual or developmental disabilities or parents or guardians of individuals with developmental disabilities. And this ensures that our work is directed by those who are most impacted by barriers to living inclusively in their community. People with disabilities have historically faced discrimination, and much of it has been perpetuated through data-driven practices. This issue is deeply rooted in how institutions collect, interpret, and use data, often without adequate safeguards or representation from the affected communities. And in the handout that I gave, we did include some of our major concerns, but one I want to highlight is the lack of informed consent and transparency in how data is used, and how that can lead to exploitation. And that's a really big concern for the disability community, because many times when there is a button that you click that you say, yes, it's okay for you to share my information, not everyone fully understands what that means. Disabled people are not second-class citizens, and they should not have to forego their autonomy, privacy, and consent for any reason. Their disability does not preclude their right to personal liberty and limited government intervention. We are asking for a human rights approach to the collection of data, and we must demand that collectors practice data minimization, strict retention controls, and secure access protocols. And all of these practices must be coupled with informed consent by those who the data is being collected from. We thank you for taking our testimony into consideration, and I am open to any questions.
Any questions? Representative Drew.
Thank you, Mr. Chair. if someone is not capable of understanding what it means to consent, would they not in that case have a legal guardian who makes that decision for them? I'm struggling to understand. Yes, I believe people should be able to consent, but if someone is unable to consent, wouldn't that preclude that? Am I making sense?
Yes, so many people would have a support system to help them make those decisions. Yes. However, there are instances where people with developmental disabilities are exploited because they are not cued to access those support systems before making those decisions.
Anyone else? Representative Plaza.
Thank you, Mr. Chair. Thank you for taking my question. It's more like philosophical one. You were talking about how data-driven practices create discrimination. So my question would be like, what are the reasons and how can we improve it? Because government to make correct decisions need data. So is it like quality of people making decision, or is it like that people are trying to save money where it's not? It shouldn't be the main concern. Could you a little bit expand like on that?
Sure. If I think I understand the question, one example is that insurance companies often use biased data to limit the access that people with disabilities have to different medical practices. So sometimes they can deny referrals or they can increase premiums.
Anyone else? Seeing no one else, thank you.
Thank you very much.
Mr. Chair?
Yes, Representative Woods.
Yeah, the proper protocol, I have a question which I just saw that I'd like to address to the prime sponsor, if at some point that would be convenient or appropriate.
Also signed up to speak is Abby Rogers from the Department of Health and Human Services.
Good morning, members of the committee. My name is Abby Rogers. I'm the legislative liaison for the Department of Health and Human Services Division of Public Health. I'm here just to talk about the technical aspects of the bill. The department's not taking a position on the bill, but in our session review of all legislation that may affect our department, we did flag Representative Howard's bill to have some statutory reference issues that we wanted to bring to his attention. Our suggestions were that instead of placing his bill in 126, that these provisions that he includes would be better in 332I. So those are reflected, I believe, in his amendment. So I'm only here to talk about those technical statutory references related to the bill. But I did notice in the amendment language, line 16 in the bill, the individual or individual's parent, guardian, or legal representative has provided informed consent. There should be an or after that, and I can certainly designate that on the amendment if that would be helpful. But we as the department met with him to explain our concerns about the statutory placement. We also wanted to make sure that if any bill that would go forward related to privacy was in alignment with HIPAA. And we made suggested some other small language changes would better align with HIPAA, and that was wanted to clarify that.
Okay, thank you.
You're welcome.
Representative Weber.
Just to clarify, are you satisfied that the changes that you were concerned about have been incorporated into the amendment, or have you seen the amendment?
I have seen the amendment. The only part which I mentioned just a minute ago is it's missing an or.
At the end of line 17?
Yes,
Okay.
yes.
Got it.
That's it. Thank you.
And that can always be done in an enrolled bill amendment if necessary.
Okay. Thank you very much.
Any other questions? Representative Woods.
Thank you. You were reading my mind. That was my question. What was the motivation? Is there anything that we should be aware of in changing from RSA 126 to 332? Is there any significance that we should be aware of in?
Sure. Well, placing the original bill placed the language in RSA 126, which is relative to health statistics, and that would create some ambiguity as that chapter doesn't function as a general privacy law, which is the function of 332 is more of a general privacy provision.
Okay, so nothing.
Sure.
Thank you.
And it also would be better. The bill's broad application would be better in 332, sort of referencing Representative Castlering's question around contractors and vendors. Thank you.
Anyone else? Seeing no one. Okay, thank you. No one else has signed up to testify on HB 1317. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on HB 1317. Our next hearing is scheduled for 10 a.m. and that time we will be hearing testimony on HB 1318. We will be in recess in the meantime.
Mr. Chairman, you might want to remind the committee members that it's our job to go upstairs and pick up copies. It's not
No, we know that.
Mrs. Grant's.
I think
To reconvene the Committee on Health, Human Services, and Elderly Affairs. The next bill to be heard this morning is HB 1318, and I'll recognize the prime sponsor, who is about to close the door to our room, Representative David Nagel.
Thank you, Mr. Chairman. Thank you for the opportunity to present this bill to you. As I'm David Nagel. I represent Gilmanton, Guilford, and a small piece of Laconia. I'm also a physician. I've specialized in physical medicine, rehab, and pain medicine for the last 30 some odd years. I work with people with complex disabilities, of which chronic pain is a common part of that. I also have advocated for patients' rights for my entire career, really dating back to when I was about 4th grade. Basically, what I advocate for is the 66 million Americans with chronic pain. I assume some of you are in this room right now. The 1.5 million are in hospice care, and I imagine some of you have had some folks in hospice care. The 50 million who have a surgery every year, and the unknown numbers of people that have a severe, moderate to severe pain from an acute injury. And the other group that I advocate for is those slightly less than 2 million people with opioid use disorder. What I'm asking you to do is basically renew our committee. And I want to explain a little bit about what our committee is. This is the 3rd time we've come to you. One of the things, take a step back. The reason why I put this thing in your packet is this is the media promoting the use of morphine for the treatment of chronic pain. This article came out in 1997. There was no opioid crisis at the time. And the only reason I include it is that everybody's blaming pharmaceutical companies for the opioid crisis. And I mean, they played a role, but it was a lot bigger than that. One of the biggest problems that created the opioid crisis was just a failure to provide access to non-pills and procedures for treating pain. What we wanted to do was to create a novel community-based integrative pain care system to basically address that issue. Nobody in the country is doing this. Everybody wants to do it. But the reality is when I started my career at Concord Orthopedics, we actually did it. Unfortunately, with the changes in healthcare over the last 30 years, it's made it increasingly more difficult because of silos and fragmentation and things like that we would like to be able to break down, and this is our strategy to try to do that. When we started the process, my good friend Senator Chanley informed me, he says, you know this is going to take a lot longer than you think it's going to take. And she was definitely correct. So this is taking longer, but it's basically, we're going through it very thoughtfully, and I think this is the best way to do it. What we're trying to do is endorsed by all those groups I listed on the first page. It's also, or promoted, I should say, and endorsed by all the groups on the second page. Where we are right now is we have figured out where we want to do this. And this is really a neat thing. We're going to be doing it at a federally qualified health center in Littleton, which seems a little weird because it's kind of out of the way. However, the reason we picked this site was because the gentleman that runs that place is incredibly innovative. He's very smart. He appreciates what we're trying to do. They already have data collection ability there. They have the ability to access Medicaid if we want to work that way. They also have a behavioral component, health component, which is really hard to find. So that's why we decided to go there. And last I checked, we have this little thing called the Rural Transformation Bill that just passed that will give us the opportunity to actually maybe fund that in ways other than what we had originally imagined, because we have never imagined using any public funding to do this. It was all going to be done by grants, and Ed is also amazing at doing that. So between Ed, me, and our good friend Gary Merchant, and a bunch of our other stakeholder friends that are listed here, we've created a work group to put that in practice. The role of the committee really at this point is not over, but their role is basically to oversee and supervise. When we started, we were meeting every 2 weeks. Now I envision we may need to meet twice in the next year to do that. However, the group, when I asked them, I said, do you think we still have a role? And they voted unanimously that we really need to continue this process for at least 1 more year. So that's what I'm asking for, is your support. And if there's any questions, I'd be happy to take them.
Thank you. Any questions? Representative Woods.
Thank you, Mr. Chair, and thanks for taking my question. Have you already been in touch with HHS regarding grants? Okay, 'cause
So,
that deadline is,
oh, no, yeah, there'll be a deadline every year. So for this year, we're looking for next year. So
Okay.
every year there'll be a new ability to submit. And Whitney Hammond at HHS works closely with Ed and I on a lot of projects, and she is very involved in that process. So yeah, no, that's not an issue and at all for us. The other thing that's exciting is promoting integrative models of care. I have to say, I'm going to applaud our state, but I've been at 2 national meetings in the last 2-3 weeks, and we got really high grades from the folks nationally about our grant for the rural transformation thing. So it's exciting. This is a neat model we could use.
Anyone else? Representative Drew.
Thank you, Mr. Chair. Can you give me an idea of the ballpark level of funding that you're getting from the grants right now, and what you're thinking about in terms of using the rural transformation funds?
That's a great question, and I'm not even sure we are going to use the rural transformation. So we're in the fundraising element of it now. The challenge of this is figuring out what we want to do. So when I started this project, our goal was that the door was open to everybody. Like, for example, UVM has a project that they do through Anthem. It's entirely funded through Anthem, and that's kind of the way we were looking at this in the beginning. So we work with an insurer. We create an insurable, what's the word I'm looking for? Every bundled service, and do it that way. We also met with Henry Lippman with Medicaid to look at it that way. The problem then becomes, well, what are you going to treat? So we're falling back on that same old thing that low back pain is easy to measure, it's common, and we're probably going to stick to that, which makes the funding part a little bit easier. But as of right now, we're looking to work with an insurer. Any other grant money is on top of that. I haven't even looked at the rural transformation thing, and until we finish the finance part, which is where we're at right now, can't really answer that question.
Other questions?
It would
Representative
not be much.
Lucas and then Representative Palazzo.
Thank you, Mr. Chair. Thanks for taking my question. Do you visualize the collection of, or the creation of clinical studies in this process?
I mean, functionally, that is what this is in a way. I mean, when I first started out, the way we did this is we had this really weird device called a telephone, and we would actually use it to talk to people. And
I think I've heard of it.
yeah, so what was neat was, like, I knew in my job that as a physiatrist, we work with all sorts of people. When you're in a community setting, it's a lot different than a university setting. So, like, trying to figure out, like, well, how can I work with this psychologist and that physical therapist and this person. So what we did was we developed loose relationships that we discussed on the phone about what we were doing and stuff like that. And then we would meet periodically, but that's how we did our team meetings and things like that. And then all of a sudden, with 30 years, I hate to blame healthcare reform, but 30 years of healthcare reform, everybody just migrated into these silos that made communication really hard. And, like, people that do what I do got kicked out of the institutions because we didn't generate enough revenue to be, important. I think that was penny wise, pound foolish. That was a national thing. It wasn't just a New Hampshire thing. So what we're trying to do, in a sense, is recreate an old wheel. And I guess you could look at that as an academic exercise. But it's not unique to pain management. This is something when we're dealing with frail, elderly, complex disabilities. Hospice and palliative care does it really well already. Or hospice, not so much palliative care, but hospice care does this really well. So how do we create those models and finance them in a way that works in our system? So in other words, when they do hospice, they bundle their care. Well, how do we do that? And it's interesting, palliative care, they can't do that. So that's kind of really tragic in a way. The biggest stakeholder that was involved in what we were doing was this hospice and palliative care organization, because they wanted to find out if we could do this or we could work on it together. How do we pay for palliative care? So as far as I'm concerned, any intellectual exercise at some level is academic. I do work with the Alliance to Advance Comprehensive Integrative Pain Management, which represents 94 stakeholders internationally, not just in the US. And we represent everybody from insurers to providers to patient advocacy groups to the DOD, the VA, everybody. And this is a big issue for them, is how do we do this? And I just find it weird with all that intellectual effort. Nobody's figured out how to do it. And I think that's kind of a sad thing. So in that sense, to me, this is very academic in that way. I'm not an intellectual academician, so I don't like publishing papers, but I'm sure something will come out of this.
Thank you.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So basically, I want to know more about this pilot program. As far as I understand, it's in Lincoln, and it will be treating people with back pain and maybe publishing some scientific paper on the results. But I want to know, like, is there some legislative framework required for this pilot program to succeed? And with this committee doing oversight of this program, what exactly entails? Like, do you envision creating some bill proposals in the future? So if you can dive in a little bit deeper.
That's an awesome question, because I thought a lot about it, because I really, in my mind, wasn't sure we needed to continue this committee. And I'll be open and honest about that. The first year we did a lot of work. We brought in people from all over the country to testify to us about, you know, how this is being done nationally. How could we do it here? What are the problems? What are the barriers? All that stuff. We worked really hard that first year, and we got a lot of information on how to do it. The actual thing will be done in Littleton, not Lincoln, but that's a problem and a solution at the same time. You know, most people don't live in rural environments, so one of our thoughts has been all along was to have both a rural and an urban component to this. So that's still open for discussion. Right now is not a really good time to plan for those things. As far as further legislation, I don't really see anything about this. You know, a response to the opioid crisis is what generated this need, not just in New Hampshire, but nationwide. Like, how do we do this? Because, you know, I testified before finance on Monday, and I showed them the VA study this. The VA actually already does this. But the VA is a unique thing, and they already demonstrated you can save a lot of money, do this and have dramatically better outcomes. And that was good information. So if the VA can do it, which that's got to be a qualified statement, why can't we? You know, so that's kind of where we are right now. Do I envision publishing a paper out of this? Not really. I'm personally no. I know Ed might be more interested in that than me. But I don't, and I don't see any other legislation coming from this at all. It's not my intention.
Follow.
Thank you, Mr. Chair, and thank you for taking my follow-up. So when you say VA does it, do you mean bundling services? And what could you describe specifically what bundling means and how it saves money and provides more services, and why without it we cannot do it?
I think a better example is hospice care. So when Medicare, whomever pays for hospice care, they basically pay for a bundle. So you get the nurse practitioner or whoever will manage the medication element of it. There may be a physical therapist involved, an occupational therapist involved, a chaplain involved, an acupuncturist involved, Tai Chi person involved, a yoga person involved. I mean, if they have those people involved, it's all covered under one bundle price. You're not billing fee for service for each one, which in theory decreases the cost to the insurer and to the person receiving the services. And we know that does that. That's exactly how the VA does it, but the VA can do that. So like a couple of years ago, I was looking to join the pain management team at the VA in Manchester. And if it had not been for COVID, that would have happened. But anyways, so They provided a number of services from interventional pain to medication management to PT, OT, acupuncture, psych, behavioral. I left behavioral care out. That was a bad thing. And Gary Merchant will be mad at me that I left out pharmacy because that's important too. But all those services are covered. You're not paying for them individually. It's as a whole. The downside, if you're the provider, you make less money. But last I checked, we're here for patients, not us. So that's the benefit to it. It's just how do you do that in our system? That's the problem.
Representative Lamontagne.
Thank you. And thank you for taking my question. This sounds wonderful. My question, though, is if you don't see legislation coming out of this, why should the legislature be studying this?
I mean, we kind of are. It's a good question, too, and I asked the same question. And, you know, that was our last meeting. That was the whole focus of the meeting is, do we need to exist anymore? And I don't have a good answer for that. The people on our committee felt unanimously that we needed to do it because originally it was created as a legislative thing. The initial part of it was to study the concept and then create a proof of concept, which we don't have. So the legislative role at this point would be to oversee proof of concept, but not to create new legislation. I don't personally see this. I think my hope is this is the last year for this.
Anyone else? Representative Palazzo.
Thank you, Mr. Chair. So, excuse me if it's like stupid question, but like, is the reason why bundles are not always available because in certain circumstances people use for easiest and most fast acting and most effective pain medication? Or
I think there's a number of reasons for that, but we are a profit-driven market and bundles don't generate as much revenue and a lot of providers don't. I'm going to look at my two doctor friends here, but I know that's part of it. Bundling is a challenge, and that's the large reason. The other thing is that we as a group don't work together well. So, like, the other project that I've been involved in was with the NFL Players Association on pain care policy, and like, when we studied players, we were trying to figure out, well, what do they do to manage their pain? And what they were doing didn't make any sense. You know, they're going to this guy, this guy, this guy, this guy here. Nobody's talking to each other. And I realized we're doing the same thing. So our role in the NFL was actually to figure out a way to bring the players together so that there would be a unified way of bringing everybody together to solve the problems so we'd resolve their injuries faster so they could go back to play and get injured again, because that's what NFL players do. You know, we also look beyond that. Like, players retire at some point and they have to deal with the ramifications of a whole lifetime of playing football. And now all of a sudden what we found is they don't have access to these therapies anymore. And what we found, interestingly, was, and sadly too, is that, you know, they don't get access to this care anymore. They have to go from this guy, this guy, this guy. They have to wait in line. The one guy said, I never had to wait in line for an MRI. Now I do. But the other thing that happens to them is they start doing all the unsavory things we're trying to prevent, like alcoholism in NFL players is very common after retirement. Drug abuse becomes very common. We had a gentleman on our committee that was functionally, did not know this, but was cannabis addicted. He thought he was just taking CBD, but he was taking 1,500 milligrams a day, and you get an awful lot of THC from that. And he was functionally stoned at all of our meetings, but he had post-concussive syndrome with chronic headaches and felt bad for him because the guy was miserable, you know. But it was interesting to compare this, and we wanted to do this, or get rid of this and do that. So, you know, I'm kind of going on long-winded, but I'm very passionate about this. And in the non-VA, the non-NFL active player setting, and probably a couple other sports, we don't do this well at all. And we really need to change that because outcomes we know, I mean, I've been doing rehab medicine for almost 40 years. We know outcomes are better when providers work together. And that's what we're trying to do. And we're trying to create something that generalizes well beyond pain management.
Anyone else? Representative McGrath.
So you're a physician. I'm having trouble understanding. So physicians make less money if care is bundled, but why wouldn't the same care be offered to the patient if that's the best thing for the patient?
Good question.
Thank you.
I agree. I know why. It's all profit driven, and that's the problem with our system. It's very profit driven, and last I checked, healthcare is about service first, profit second. And that to me is the problem. And when you have a system that, you know, when we first started, I mean I've been doing this for 40 years, which is hard to believe, but like I don't think we got paid, but we didn't look at profit as a primary motivator when we started. And doctors got paid good, but that's not true anymore. It's become a very profit driven system. So you look like, for example, this is a true example. I did general pain management for years. That was what we did, is bring people together to solve a problem for an individual person in a patient-centered manner, which is the word everybody uses now, but we did it back then. We said, we need to do this. Well, we did it fine then. So all of a sudden they find out, I'm not generating any revenue because you can't generate any revenue. So all this pressure on me and people in my field to start doing what's called interventional pain management. There's virtually no evidence base to justify long-term outcomes of interventional pain management. But everybody wants you because you generate a lot of revenue. When I switched my practice from one to the other, my revenue increased by 5 times. But societally, I think I was doing a much worse job because I wasn't doing integrative care anymore. And to me, that's a problem. And that was the whole reason I wrote the book I wrote on pain management, was out of frustration because we're not putting our dollars in the right place. That's my opinion, and I'm sticking to it. But you bring up a very important question, because I think until we start to look at healthcare that way, that we're going to continue doing what we're doing. And if you rate our healthcare system, our outcomes rate very poorly relative to other countries.
Follow up.
So you're saying that the doctor who has this patient doesn't want to share the patient because they'll lose revenue? Like if they integrate the care?
I don't think it's quite like that, but no, I don't think it's not the issue of not sharing, but you may be stuck within your silo. That's true, because I've seen that plenty of times where, well, we don't want to send this patient over here. We're going to keep them within our building. So, like I've seen that especially for physical therapy. Like we don't want to send, I got to know all the PTs in the state, so I know who was good with what. And I said, well, I want to send this. I mean, in our office, we never did this, but in other offices, I'm pointing to him because we were partners for a long time. And he's smarter than me. But we would see patients. I really want this patient to go here. Well, you can't, because in our silo, we don't allow that. So that was a new thing, in the last 30 years. That did not exist before. And that's pretty, to me, scary. That's my opinion.
Anyone else? Representative Tejas.
Thank you, Mr. Chair, and thank you for taking my question. Just as a follow-up to the last conversation, I'm wondering if you can differentiate between the sort of profit seeking that you were discussing being at the individual clinician level versus like the health system and practice level, because I think that's an important distinction when most docs are employed.
I'm glad you raised that, because when we started, I think 17% of doctors were employed. Now it's over 80%. So now you do what you're told, which is true, I think, in a lot of settings. And profit is the motivator for a lot of settings, and that to me is a problem. So, I mean, anyways, I'll just answer your question. Yes, you answered it for me, but yes.
Anyone else? Seeing no one else, thank you.
Thank you.
No one else has signed up to testify on HB 1318. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on HB 1318. We have in 5 minutes. At 10:30 we will be hearing HB 1321. We'll be in recess until then.
Trying to make up for lost time now.
Okay, good morning and welcome back. We are now Health and Human Services and Elderly Affairs Committee. We are now going to be hearing about HB 1321. I will recognize Prime Sponsor Representative Wade. You don't need to do it right now, Representative Wade, but we do need a pink card from you before you leave us today. So.
Yeah, I'll get that to you. Sorry for the delay.
That's
Got
fine.
the wrong room
I
upstairs.
said you're a busy lady this morning.
Oh yeah. Alrighty. So thank you, Mr. Chair and members of the committee. For the record, I am Representative Alice Wade, representing Stratford 15 and Dover Ward 2, and I'm here today to introduce HB 1321. So last year in Texas, Jennifer Cleveland died after receiving IV drip therapy at a med spa. The person who inserted her IV wasn't a nurse, wasn't a doctor, had no medical license, and when something went wrong, there was no experienced medical staff on site to save her life. You might assume that only licensed medical professionals can insert IVs into patients, but you'd be wrong. In New Hampshire right now, anyone can open a med spa in a shopping mall and offer IV drip therapy, no medical license required, no medical supervision on site, and practically no oversight. Med spas offer wellness IV drips that might include things like vitamins, nutrients, electrolytes, or other sorts of medications injected directly into your bloodstream. When administered properly, there are lower risks, but done improperly can cause serious harm to patients. Improperly inserted IVs can cause air embolisms, infections, vein damages, and overdoses. One med spa actually ordered counterfeit Botox off of Alibaba and injected it into patients without telling them where it came from, after people were harmed. And because these aren't licensed medical facilities, there's often no malpractice insurance and limited recourse for patients if they are harmed by these treatments. After the death in Texas, their legislature passed Jennifer's Law, requiring medical licenses for IV procedures. This bill would do the exact same thing for New Hampshire. It's pretty simple. You know, if you're going to be inserting an IV into somebody's bloodstream, you need to be a licensed medical professional. So that might be a physician, physician associate, advanced practice nurse, or a registered nurse. This doesn't shut down med spas, it just requires the people performing medical procedures have medical training. That's just common sense. Most people already assume this is a law, and we're just closing a dangerous gap before someone in New Hampshire gets seriously hurt or killed. I urge the committee to vote ought to pass. Let's not wait for a tragedy to act, and I'm happy to answer any questions.
Okay. Thank you, Representative Mason.
Thank you for taking my question.
Yeah.
I wrote this down because I was reading through this bill, and can you explain why licensed paramedics who are authorized in New Hampshire to initiate IV access and administer medications under physician-approved standing orders in high acuity emergency settings are excluded from administering elective IV therapy under a physician supervised in a controlled outpatient environment?
I might be open to that. It's really more a matter of, you know, requiring at least some degree of medical training. Right now, there's basically zero requirements at all. There's no particular requirements of having a certain level of training. IV drip therapies might run their own training programs. If there are other groups that would make sense to include, I'm open to that. This is basically just modeled off of Texas's law, Jennifer's Law that I mentioned. And so this is not my background in particular. I'm an engineer, but I thought that this was a very important gap that we needed to close in terms of potential oversight issues.
Thank you. So why limit it though? I know you said you're open to it, but why limit it to just physician? And so where do we draw the line? Why can't we just have anyone who's licensed or, you know, to to do an IV be able to do that? Like, how many more aspects do we have to put on this to allow for that?
As I said, this is modeled off of Texas. I did not in particular select these groups. This is just what the Texas legislature had decided was the appropriate groups of people.
Yeah.
If there are other groups, especially like a trained paramedic who knows how to insert an IV already and has done training and does that in a medical setting, that, at least on first impression, does sound to me like it would make sense. So I would be more than happy for a committee
Yeah, because
amendment.
there's many businesses in New Hampshire that this would affect
Yes.
negatively. Okay.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So I ask for some clarification what's happening and not happening in New Hampshire. And also you provided several lists. So one list was vitamins, nutrients, and electrolytes, but then you mentioned Botox, and I'm not sure if Botox fits to those three categories. But then we were discussing that some of the procedures done in New Hampshire are actually done by licensed paramedics. So what's your understanding of what are situations that you're trying to prevent in New Hampshire?
Yes, so Botox in particular, that was more just a general example of the kind of under-regulation of a lot of med spas. That it's, I mean, you literally can open them in like a shopping mall and not really have a particular oversight in terms of training of the employees. And these are potentially risky procedures, and they can be using drugs that are not purchased through, standard, means, purchased off of Alibaba or things like that. This bill does not touch on that. That was more of a broad example. So in terms of IV drips, that is, they might inject nutrients, they might inject electrolyte treatments. These are voluntary treatments. These are not prescribed by a doctor. It might be like a wellness thing. And they have expanded quite a bit in recent years. I believe it went from around 1,000 around the country in around 2010 to a couple of years ago. We're now over 13,000. And most cities, there's basically more med spas in cities than there are like dermatologists or other like plastic surgeons or other doctors like that. So those are the treatments being done, and I had looked into it, and I have seen multiple in the Seacoast, at the very least, med spas that offer these treatments, these sorts of nutrient drips, and even on their websites it says like we are not medical professionals as like a disclosure, which is a bit concerning. If I were going to one of these treatments, I would want it to be done by somebody who knew what they were doing.
Representative Lamontagne and then Representative Mazur.
Thank you, and thank you for taking my question. I feel really naive that I didn't know there were a lot of businesses doing this in New Hampshire. But this wouldn't apply to Botox in general because that's not an IV, right?
Correct.
But are you aware of, in New Hampshire specifically, what are the most common IV treatments that people are doing?
Off the top of my head, I don't have a particular list of them. I know, at least on my preliminary research, there were those sorts of, it's a lot of wellness treatments is to the best of my understanding, what the treatments are typically for. It's voluntary. It's people, it might be part of a beauty treatment. It might be part of somebody looking to be healthier. And I'm not looking to prevent people from seeking out these treatments. I just want to make sure that they aren't harmed, either through improper dosage, improper insertion of an IV, and lack of medical professionals on site to potentially address complications. Because in the case of Jennifer, down in Texas where she died. The problem was the IV was inserted improperly. She began to have other complications and started to bleed out, and none of the staff on site knew what to do. They weren't trained effectively enough, and that is why she passed away. And my stance is I appreciate the quick action that Texas took on this issue. I would rather not have us wait for somebody to die in New Hampshire for us to try and take some proactive action on this. I'm open to tweaking it. I understand that some businesses may find it difficult. So if there are other categories that would make sense to include, like paramedics, and I appreciate the suggestion, I'm more than open to that.
Representative Mazur.
Yes, thank you for taking my second question. So, Section 3 says that is not administered in a physician's office. So there are businesses in New Hampshire that go to people's homes and do these IV therapies, paramedics. So are you limiting these treatments to a physician's office in this bill?
So that is not my goal, is to limit those types of treatments. In terms of my understanding of it, this is meant to be focused on elective IV therapy, as stated in part of the definitions. And Section 2 is that sort of like temporary discomfort or temporary wellness. If there would need to be some sort of amendment to make that language more clear, I'm again open to that.
Thank you. Follow up.
Follow up.
So would it be true that people that are doing these treatments would sign liability forms and know the risk when they undertake these treatments? And it should be their choice?
They may sign liability waivers. I'm sure that some sites have that. However, again, this is something where, a lot of those forms, people sign them and they don't, people don't read through all of that, and I get that that's a personal determination. I think when you tell them that, their IV therapy, because in those disclosure forms, they don't tell you that the person who's administering it is not trained. They don't tell you that. They say, oh, there might be risks and complications, but I think a lot of people would assume that if they're getting this sort of a treatment, that it's from somebody who is medically trained, medically licensed, who knows what they're doing. This is seeking to basically align patient expectations of quality care with that. I'm sure Jennifer may have signed a liability form. They didn't have malpractice insurance. They didn't have the medical staff on site to deal with that, and she died. Again, I don't want to wait for somebody to die here before we do something. And I don't think a liability form adequately addresses that.
Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. If we were to amend line 10 and 11 so that it was not restricted to a physician's office, but tied, and I don't have the language off the top of my head, but tied to ordered and supervised under the license of a licensed professional, would that perhaps go some way to alleviating the problem of it's not where it's administered that's the issue, it's that there isn't supervision by somebody with the appropriate training?
I would agree with that, yes.
Thank you.
Anyone else? Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my second question. So, are you aware that medical errors are one of major causes of deaths in this country, and Hopkins research estimated that in 2013, 251,000 people died in the US due to medical errors. So, like here we have one death for this industry versus the 250,000 deaths. So, have you estimated what is the risk level compared to other procedures that are done by licensed medical professionals?
I haven't done those exact calculations. It's one thing where this industry is expanding extremely rapidly, and standards aren't really catching up. And it's not just the one death. There's been thousands of people who've had severe medical problems that may end up becoming chronic and permanent. The death in this case was the worst example, and I would believe that you would have a much lower chance of complications. Obviously, it's never going to be perfect. It's never going to be 100%, even with licensed medical professionals. I'm not saying that is necessarily, a fix-all solution, but I would trust a licensed nurse a lot more than I would trust somebody off the street who maybe went to a 3-day course and then started sticking IVs in people, in my mind.
Representative Palmer.
Thank you, Mr. Chair. Thank you for taking my question. So I'm sort of also a little bit like, really? There's nothing that... so in looking at this, I was just looking it up. So a barber has to have 800 hours of training and be licensed, and a nail person has to have X 100 hours and be licensed. How did this sort of slip through? Do you have any idea?
I think in some ways it's because there are plenty of licensures when you're doing this if it's a prescribed treatment. Obviously, like if a doctor would prescribe something like this, it would be done in a medical facility, and that has all of the existing licensing infrastructure. Part of the reason this has slipped through the cracks is because it is a voluntary wellness treatment, and so these treatments are not considered medical procedures in that way, and so that's sort of how it's slipped through the cracks, and effectively we just haven't caught up to it. Given how fast this industry has expanded, in the span of 10 years, we've had 10 times the number of these centers open up, and that the most recent number I found was from 2023, and I'm sure even more have opened since then.
Representative DeLamus and then Representative Kesselring.
Thank you, Mr. Chair, and thank you for taking my question. You mentioned that there are thousands of cases where there have been injury. Do you have the stats on that? Could you send that to us?
Yeah, I can find that and send that over.
Great, thank you.
Representative Kesselring.
Thank you, Mr. Chair, and thank you for taking my question. So in your research, have you found any licensing that's required for these type of procedures currently?
So to my knowledge, it is basically state by state. There's no federal requirements that I know of.
Follow up. Thank you for taking follow up. So in New Hampshire, you specifically don't know?
I don't believe so, and no law like this has been passed in New Hampshire.
Okay, thank you.
Anyone else? Okay, thank you.
No problem. Thank you for taking my testimony.
Before I call up the next person, just to review our procedures here, we give extra time to the prime sponsor to lay out the plan, the reason for the bill being introduced, and then we ask all other testimony to be kept to 3 minutes and to allow time for questions. So next up is Matthew LaRanger from Derry. And again, sir, please keep it to 3 minutes.
Hi guys, my name is Matthew LaRanger.
Oh yes, there you go.
Hi guys, my name is Matthew LaRanger. I'm the owner and one of the founders of Hydropeutics IV Hydration and Medical Aesthetics out of Manchester. I am a licensed paramedic here in the state of New Hampshire. Just my job here is to educate everybody as to what a paramedic and the EMS industry does. So I have over 2,000 hours of clinical experience, including IV hydration and medication administration, and that's in hospital and out of hospital. I currently work for the town of Merrimack on the ambulance service there, so I see patients on the regular. In regards to oversight, we operate on an ambulance with no direct supervision. We have protocols that we have to follow. These are all established by the Board of EMS. And we have experience in regards to diagnosing and treating these patients by ourselves with no extra supervision, because that's what we are trained to do. With that said, we opened up Hydropeutics because we want to establish a bridge between home and hospital. On several occasions, me and my business partner have recognized that a lot of individuals will call 911 and in the hopes of just getting a bag of fluid at the hospital. So we're trying to establish a bridge to alleviate stress on emergency rooms and urgent care centers, which was our main goal, is to make this affordable and accessible to everybody. With that said as well, we have to keep proper documentation per our insurance company. So we keep charts and do evaluations on every single patient. I will admit that Dr. Lee does oversight us, but that's with written order protocols that we have to follow, no different than what we do on an ambulance. With IV services, we make sure we monitor the patient throughout the entire service. We monitor vital signs as needed. We document everything that we do. We have liability forms that the patient does sign, and these explain very thoroughly that we are trained. We advertise that we are trained. And we also have the education to explain to a patient that these are not cures. However, this is all supplemental and elective. So we do make sure they're aware of that. However, some of our patients do have flu-like symptoms. We have helped some hospice patients and cancer patients in the field that are kind of just looking for some pain relief. We don't carry any narcotics. We carry simple, like, non-narcotics, like Toradol. I don't know if anybody's aware of Toradol. Yeah, it's a very, we've had a lot of clients and patients of ours that are very thankful that the service exists, because they either just don't want to leave their home, they don't trust the emergency department, and we just make this accessible to everybody. So,
Okay, thank you. Representative Weber.
Thank you, Mr. Chairman, and thank you very much for taking my question, because this is all new territory to me. First of all, as a threshold question, am I understanding that you're opposing the legislation?
I'm not opposing legislation. I do agree with regulating this. I would like to see the amendment to include paramedics and another level, which is called advanced EMT. And again, this is an education thing. There are different levels of EMS providers in the state of New Hampshire. There's emergency medical responders, emergency medical technicians, which is the lowest level for advanced life support, AEMT, which is where you learn how to do IV therapy in a moving ambulance and in hospital, and then paramedic, which is equivalent to, and this is my ego speaking, equivalent to or greater than a nurse on some level, because we are provided some procedures that we can do in the field that are doctorate level, like intubation and cricothyrotomy and transcutaneous pacing, and these are very complex procedures that some nurses are not allowed to do. Go.
So, as a follow-up, so would you be willing to work with some members of the committee on establishing language that would distinguish the services that you are providing by people with training and protocols?
Absolutely.
And all that kind of supervision that would distinguish them from a facility that had people administering IVs with no training?
Absolutely. I 100% agree that you should have some training to do this. Okay. We opened up January 2021, right during COVID, when this was very sought after by a lot of people. They were consistently looking for a way to alleviate their flu-like symptoms and COVID symptoms. And we made that happen for a lot of these people. So there's a lot of people grateful. But yeah, I 100% agree that there should be some regulations in place on who can and cannot administer this. And again, I follow up with that. We would like to see the addition of those two professions of paramedic and AEMT.
Thank you very much. Representative
Mazur.
Yes, thank you for taking my question. So you mentioned the way you do this in an ambulance. So the way this bill is written right now, would this affect how things are done in an ambulance?
So doing our research and how we were able to do this, and this is where we want to kind of create more jobs for our industry, as we are already being utilized in hospitals, urgent care centers, dental offices for anesthesia. There are even paramedics that are being contracted to be the second set of eyes for cardiologists to make sure that 12 leads are read appropriately. So there's a huge industry for paramedics that's being underutilized, in our opinion. This would not affect what we do on the ambulance, as that's regulated by the Board of EMS. Also, another educational standpoint, as we were mentioning Botox, registered nurses, recently the Board of Nursing just added Botox to their nursing protocol in the state of New Hampshire, so we were aware of that as well. But no, this would not affect us on the ambulance by changing this language, as those RSAs are controlled by the Board of EMS.
Representative Tejas.
Thank you, and thank you for taking my question. So just to make sure I understand, thank you for the great education you're framing up for all of us. So the example you're sharing of the business you run, or the organization that you're involved with, is an ambulance that has trained, experienced paramedics and AMTs who are providing these therapies, but it still is under like a physician's.
Are you talking
order.
about Hydropeutics, our company,
Yeah,
or the ambulance service? So
Well,
the two
how
different
about
things.
both, to be clear?
So the ambulance service is run by a government organization. Every town has an ambulance or contracted ambulances like AMR, American Medical Response. I work for the town of Merrimack as a firefighter paramedic. Hydropeutics is a standalone small business where we do not have an ambulance, but what we do is we book appointments with clients. We do an initial assessment over the phone, including grabbing charting paperwork. We send a paper or a form to them explaining the terms of service, HIPAA liability, including patient medical history, allergies, symptoms, all the things that they're dealing with. And then we do an assessment to see if this is the right fit for them. And if there's any questions, then we send it to Dr. Lee if needed. For example, one of our infusions that we offer is an iron infusion. We do not take patients requesting an iron infusion unless we have labs or an order from a prescribing physician. It doesn't necessarily have to be our medical director. It could be another outside source.
Okay, so sorry, just was trying to clarify. So, is the Hydropeutics, is that similar to the sort of Medi-Spa that it seems that this bill was?
In the eyes of the
about,
state of
or-
New Hampshire, when we opened up, we were considered a med spa, as that's what we were doing. But we wanted to make sure that we were following all appropriate rules and
Right.
regulations that did exist. For example, all of our pharmaceutical stuff we obtained from McKesson, which is a medical supplier, which is the same service that hospitals and ambulances get their stuff from. And every single vitamin that we administer is from a 503A and 503B compounding pharmacy that's regulated by the FDA.
So you're already operating by sort of high quality standards.
We are.
And this is meant to prevent people who aren't going to just do that on their own.
Correct.
So it sounds like you're saying everyone is trained and you still are operating under a physician's license or authority.
We are.
Okay.
And the
so-
way that works is that
Yeah.
I'm technically an extension of Dr. Lee's
Right.
license. Because I have the training to be able to recognize a stable versus an unstable patient, he trusts me as a paramedic 100% to make that decision in the field on my own, just no different than an ambulance.
And you have the
That's your
training to
first
handle it.
follow-up.
Oh, sorry. You have the training to handle anything bad.
Correct. We carry emergency medications with us, including EpiPens, epinephrine, Benadryl. We even carry Narcan for the occasional patient that may want to experiment after we start an IV. And I will give you an example. I had one client that went to the bathroom and he was in there for about 20 minutes. Thankfully, he didn't actually use any narcotics. He ended up falling asleep because he had a 24-hour shift. So I was prepared for that, though, and we're all trained emergency service personnel at our company. Paramedics are trained to handle emergencies in high-stress environments, so we are 100% prepared for all that stuff.
Thank you.
Representative Kesselring.
Thank you, Mr. Chair, and thank you for taking my question. So, trying to wrap my head around understanding how the language could be crafted. And with that, I understand that basic EMTs do not have the ability to start an IV, correct?
Correct.
So with that mindset, would we want to follow more of the nursing guidelines, as you said, because the EMT guidelines are not kind of as clear for that other than what the nursing says.
So, as I had mentioned, in the New Hampshire Board of EMS, there's 4 sections of protocols which each individual EMT provider has to follow. And I wish I had the example with me, but EMT basics are trained to a basic life support level. That does not include invasive procedures like IV or injections. However, they can do some basic injections like intramuscular injections to save somebody's life in the case of an anaphylactic reaction. As for the nursing protocol, here's the interesting thing, another educational piece. Some nursing programs do not teach their nurses how to do IVs. They do that on the job, whereas paramedics are required to start a minimum of 150 IVs in their education in a hospital setting. So to follow the registered nursing protocol, I think that might be a little tricky as they're 2 completely different educations. So,
Well,
Thank you for taking the follow-up. So is there any other national standard or anything else that you know of about training for IVs? You mentioned 100 hours or whatever. Is there like a standard for that nationally?
So the National Registry of EMS, or NREMT, which is the regulating body federally that controls all the EMS licenses in the country, they require you to have IV training at the AEMT and paramedic level. So there is a standard for that. As for the nursing, I don't know the answer for that. I know that some nursing programs do not offer that, and that's because I've tutored some nurses. So.
Representative Weber.
So just to circle back, and that's sort of a follow-up to Representative Kesselring's question. If we were to take the piece of the definition that's tied to a place in a physician's office or health facility, and tie it more to the licensing of a professional, to the various tiers of professional licensing in accordance with the established protocol for whatever that license is. Would that sort of solve things?
I think it would, because that would help alleviate the piece where this may only be done in office, and that will expand it to making healthcare accessible to people in their homes. So I think, I don't know if that answered your question.
And may I just have one follow-up? What I'm trying to get at is that I think what I'm really concerned about, I won't speak for Representative Wade, is that the people doing the procedures have exactly what you were describing, of the ability to assess a situation and know, first of all, how to do whatever service there is that they're doing, and secondly, recognize when something has gone wrong and know what to do about it then.
Yes.
So if instead of tying it to a location, because there are all kinds of different locations, if we tie it to people's licenses and existing protocols so that we don't have to specify every single one, is that an approach that you think might work for this?
So I don't follow the Board of EMS protocols for the actual supplemental IV service.
Okay.
I do if there's an emergency. And I'll give you an example. So Dr. Lee, to answer that question, Dr. Lee wrote all of Hydropeutics protocols and signed off on them. If there's an emergency, he knows and I know that I will do the appropriate things to help that person, including up to calling 911 and going to the hospital with them if there's a lower level provider. We did have a situation happen where we had a patient that had an anaphylactic reaction, including a low blood pressure, where I activated the 911 system. Thankfully, there was a paramedic that showed up that I transferred care to, but I did everything that was necessary to provide aid to that patient until they got to a higher level of care. And what this is each individual company has their own protocols. When a paramedic is working outside of the EMS system, it's different.
Okay.
So that'll answer your question.
Thank you for making thank you for making that distinction, because I was hoping that there was a way of including everything within existing systems, and there really isn't, because
yeah, it's called community paramedicine. It's something that we haven't adopted here in New Hampshire, and I'd really urge everybody to start looking at this subject. There's some states that have integrated this into their 911 system, where paramedics have an expanded scope of practice, including up to IV antibiotics and lab draws in the field. So basically, when you call 911, it gets coded as a Omega, Alpha, Bravo, Charlie, Delta, Echo call, Echo being the worst, Omega being the least. Some of these states have said that Omega level calls don't get an ambulance, they get a community paramedic that will go out and do essentially what we're doing, and assessing the patient, treating them, getting antibiotics for them, whatever we need to do. That's just a very light example, but yeah, that's something that I would love to work with everybody on in creating and establishing here in the state of New Hampshire to someday alleviate stress on emergency departments.
Gotcha. Thank you very much.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So, bringing together previous testimony and your testimony, do I understand correctly that in your company, specialists are officially trained and have at least some certifications, but some of your competitors they are not trained and not licensed, and also on statistics that thousands had severe medical problems in the U.S. In this industry. So we heard that there was an anaphylactic reaction in your company, but generally in New Hampshire, how many severe medical problems we had in New Hampshire with this kind of procedures?
We have only one issue to report out of 5 years of operations, and typically it's not necessarily an allergic reaction to the vitamins that we're administering, it's to the preservatives that a lot of these clients don't know or are not aware that they have an allergic reaction to. This person had a severe anaphylactic reaction, and we found out later it was because of a preservative. Some of these vitamins have preservatives to extend their shelf life. We follow procedures that as soon as you open a vial, especially if it's a multi-dose vial, you have to throw it out within 28 days. So that's what our procedures and policies follow. As for around the country and even in the state of New Hampshire, I don't know of anything that is like, I knew about the Jennifer's Law. I did not know that it wasn't a licensed provider administering that. We try to stay away from that, which is why we did a lot of research and tried to understand this industry before we opened up shop. But I don't have any other incidents to report, and I know that a lot of my competitors, they are all 100% licensed nurse practitioners, PAs, paramedics, registered nurses. We even have a registered nurse on our staff as well, who was an emergency room nurse at one point, and she's now at the cath lab at Catholic Medical Center. So yeah, a lot of my competitors are all licensed as far as I know. I don't know of any, unless it's like an underground business that I'm not aware of. Everybody that I know is 100% licensed and following regulations and guidelines to the best of their ability.
Representative Drew.
Thank you, Mr. Chair. So, by your description, you were working for, hydroponics?
Hydropeutics.
Hydropeutics.
That's a different thing.
Yeah. You were working for Hydropeutics.
Yep.
And you had a reaction, and you called 911.
I treated the patient accordingly, including IV Benadryl and an EpiPen, and then initiated the 911 system, which is what I'm trained to do anyways.
Right. Yeah. So let's assume that someone was administering this who was only trained to do IVs. The procedure then would have been for them to call 911. So what would be the difference between your treatment and handoff versus them just handing off as they don't have the skills or the training to do the treatment?
So that's something where we have to educate and train. We don't hire anybody that doesn't have emergency experience. That's one of our rules that we live by. One of our paramedics is a dairy paramedic. Another paramedic that we have works for Boston MedFlight as a critical care specialist. So I can't speak on behalf of registered nurses or paramedics for that matter, that are not in an emergency setting that don't know what to do. But one thing that we would like to see is that they have some type of level of emergency training. so they know what to do in case of an emergency. However, if they do not have that training, it is 100% expected that they will initiate the 911 system. And most nurses, they do get that training. From my understanding, they do get that training for medication treatment in nursing school, so they know what medications need to be administered in case of an emergency, including Narcan, Epi, and Benadryl. But also, there has to be some type of training in-house. There has to be. That has to be a policy, and that's one of our policies, is that you get that training in case you're not that level of criteria or have emergency experience. For example, a registered nurse that works in a nursing home may not have started an IV in 20 years. So I would shy away from somebody like that. But if we were to hire them, we would make sure they have the experience to know, and continuing education is the word I was looking for, to make sure that they keep up on their skills.
Follow-up.
So what you're saying is that there's a number of licensed medical professionals who you wouldn't hire because they don't have these skills.
Correct.
If you had someone who had these skills but was not licensed as an AMT or a paramedic, would you consider hiring them?
No, and typically somebody that doesn't have this experience wouldn't have that type of training unless they're a bookworm and just like to know things. So that's been my experience.
Okay. Seeing no other hands up, so thank you.
Thank you.
Also signed up to speak is Patrick Lee from Bedford, New Hampshire. And again, sir, if you could keep your testimony to 3 minutes, please. Hit your button on the. There you go.
Is that on? Okay.
It is, yeah.
My name is Patrick Lee. I'm one of the ER physicians at Southern New Hampshire Medical Center. I worked at CMC, did my training down in Florida. So, Matt and I are business partners. When as you, I will keep this short because you guys are already here long enough. But COVID hit us. I worked in the emergency department. Nobody could come in. And so this idea was born out of, hey, what can we offer patients in their own home? And so, it's funny because I hear what the proposed representative, who's not here anymore, I guess, had been saying, which I think the idea is good, right? I mean, you want to be safe. You want to have a regulated kind of industry. I'm surprised that you can open up and order drugs without a license, because when we tried to get into this industry, it was relatively new. There was not a lot of stuff going on in the Northeast to kind of follow. And I found it hard to even order for myself, being a licensed medical professional, navigating through all the different ways and, getting a hold of the drug reps. And so, I don't know. I feel like there's probably a way, I guess, for you to do this, but I just feel like it'd be very difficult. So, I think Matt will answer a lot of questions specifically, and you guys can ask me all kinds of questions to follow up. I can answer more medically. I also sit, and I'm not represent them, but I also sit on the board that basically make protocols for the EMS guys. So, one of the things that we were concerned about with the bill, and you guys already addressed this, was that, hey, can we amend this? There was no box to amend. It just says to oppose, so I had to click oppose. But basically, just to kind of broaden that a little bit, just because it would affect a lot of businesses that does use paramedics and AMTs, and I've known these guys. I look young, but I've been doing this for 22 years, and that's not including med school. And so, so I feel like, you're kind of, if we're just going by this bill, then it's really going to affect a lot of businesses, and I just don't feel like that is something that, and it sounds like maybe there was an educational thing, because obviously not a lot of people know about it, or, oh my gosh, how can somebody just, get off the couch and start an LLC and start buying meds, online maybe. We really consciously made an effort to be super safe. Matt can attest to the fact that, we would sit together and I'd be like, okay, we need the malpractice, we need business insurance, we need, to hire medical professionals, so, yeah, so I don't know what you guys can do with this, whether or not it's an amendment or coming back to it, and obviously working with Matt or I even, yeah, so that's it.
Thank you. Representative Brew and then Representative Kesselring.
Thank you, Mr. Chair. What would you consider to be the minimum level of training experience for someone that you would hire to do this job?
Yeah, it's very clear. I mean, and I didn't, when I came to this meeting, when I heard the testimony, one of the things that really surprised me is I didn't realize that you could just somehow poke somebody with an IV and know how to do it without proper training. I think there is some minimal training. I even tried looking at YouTube, okay, how do you start an IV? And I guess you could do it that way, but then you'd have to have willing participants that would let you stick them, right? And how many times is that going to happen? Maybe your drunk friends and, whatever, but you know what I mean? And like Matt says, there are programs in different, Rs that you had included, nursing and physicians and stuff. And I mean, I could even argue with you that, hey, in med school, I wasn't formally taken to somebody's room and start sticking needles in them. Now, I was in emergency medicine, so I did that a lot. But I can tell you, I have friends in radiology and other things. They would never, I pulled them out right now into a plane and say, hey, can you start an IV? They're just going to look at me like, okay, well, I guess I can do it. But, they wouldn't have had probably the 200 hours of training Matt had. So I guess the minimum is hard to say because, there are professions that actually, sounds like they should know, like a physician. And, my comfort with maybe their IV insertion may even be lower than a paramedic, right? I'm not saying that obviously one of my friends who's done this for a living as an MD is going to, doesn't know all that stuff, but it's one of those things where I guess the minimum was some type of medical training, but I just don't know how to quantify it. I think, if you were going to amend this, then at least have paramedic, AEMT, and then maybe higher up. But Matt already said this too. It's every profession kind of has their own little regulations anyways. Like, when I did my medicine versus a nursing program, and I didn't know this either. When I started working with nurses, they didn't realize certain nurses don't know how to start an IV, and then they come to the emergency department, and part of their training as they flow through is to get a chance to do it. So that when they go even the floor of the hospital, they don't put IVs in. So, and I don't know if you guys knew that. I didn't know that as a doctor. I walk, they call the emergency room doctors or the ICU doctors and, hey, can you guys come up and put an ultrasound guided IV? I said, well, don't the nurses do that? I said, no, we don't know how to do it, or so it's just, so even that, like for me, it just blows me away. And so to answer that question is really hard to say. I don't want to be like the leading expert in knowing that, but I can just tell you that, hey, in order for you to insert an IV in someone, there has to be some level of training that you've already had. And so when we hire people, we are conscious of that, right? So if somebody just comes in and says, I'm a barber, can I work with you? We would say no, obviously.
Thank you. Thank you. We understand. Representative Kesselring.
Thank you, Mr. Chair. So I want to pose a question to you a little differently, because it sounds like what you've talked about. Would you say that it would be a better way for us to go about this would be that any facility doing this has to have a medical, like a physician or a medical person to have as part of their process in order to get this going, let's say, or not so much licensing, but requirement for that? Does that make sense?
Yeah, I believe so. I mean, when I researched this, most of the places, if not places that was basically online or, just researching it, there is some medical direction at some level, whether or not it's an NP, PA, or MD. A lot of the legitimate sources of the medications we go with McKesson and all the pharmacies, you you can't get the medications and the IV fluids without me, copying and pasting my medical license. We don't do narcotics, but they want a DEA number license. I do that too. So, so there are a lot of checks and balances already in place, I find. Now, maybe I'm wrong. Maybe you can just go online and order a bag of IV fluids that's made in some garage. I don't know how I would do that, but I guess that's possible. So I don't know how you guys would regulate that, right? Because that applies to every product.
Thank you.
So.
Representative Weber.
So I'm going to ask a question. I really want just a yes or no answer, if I could. Am I correct in thinking that there is a complete distinction between the kinds of services that your company is providing, which I didn't know existed, and the kind of med spa experience, which sounds to me to be very different from the service that you are providing, and that what we need to do is distinguish between those two things, so we're not getting in the way of people who are legitimately trained and know what they're doing, and the people who possibly don't know what they don't know.
Yes.
Okay, thank you.
Seeing no one else, Representative McGrath.
So 2 questions. First, would you hire a phlebotomist who's trained to start IVs?
So technically, phlebotomists take blood from your veins. They don't actually insert IVs. There are places you can go to in a hospital where there is a person that puts in IVs. In our company, that would limit us. So, for us, because we're kind of not big, we're small, we try to be more efficient. So we ourselves probably wouldn't. Now, if we grow to a point where, there may be 2 people sent to a place and one needs to put an IV, the other one administer the IV medicines, I guess I could see myself and, Matt hiring someone, but it wouldn't be somebody that we would hire just because that's limiting our ability to give service.
Follow up.
So a paramedic can go in and treat somebody without bringing them to the hospital if it's the lowest level of care. So I know a couple of people who have conditions where they periodically have to call an ambulance and they end up getting fluids and then get sent home. If that's the case, if the patient calls hydroponics as opposed to 911, would you be able to bill insurance for that?
Well, it's interesting you say that. Initially, we were just doing FSA out of pocket. Then we realized through the 5 years that we've been in business that a lot of patients may even want to go through insurance, and we would actually, be able to offer it to patients that not necessarily be able to afford that. And so we pretty much got all the commercial insurance in place, except Medicare's taking a while, which usually is the case. But so we're working on it. I don't think every place does that, but yeah, I mean, you can bill through insurance, and part of my thing with Matt is that it just looks more professional, I guess, and offers more services, instead of being called a med spa, which unfortunately is the label that you get. So you can, go through insurance. We don't, not yet. I don't want to belabor it, but yes, we plan on being able to offer it, but not right now.
Representative Mazur.
Yes, sorry. Thank you for taking my question. The wheels are spinning, so I hope this makes sense. So just because there isn't a law that specifies minimum requirements for IVs, does it mean that doesn't exist? Like, what about through OPLC or something, licensing outside of a law? Like, maybe it's a question to myself, like, should we be doing more research to actually see if there isn't anything that out there that specifies minimum requirements for IVs?
Yeah, I mean, that's probably a good
Do
idea.
we know for a fact that doesn't exist?
Right, I don't.
So, okay, because I'm worried about affecting too many people. If we don't do this right, I'm afraid of who's going to be affected. So,
And truthfully, I didn't know that this bill was up until 2 days ago when somebody happened to notice it. And so I'm sure there are a lot of people who is in this industry or affected by the industry anyways that may not know.
Thank you. Anyone else? Seeing no one else, thank you. Also signed up to speak is Candace Burns from Stratum. And again, if you could keep it to 3 minutes, please.
I apologize, I'm a little nervous, and I'm going to read from a prompt here just to keep myself on track as well. Mr. Chair, members of the committee, thank you so much for the opportunity to speak here today. My name is Candace Barnes. As you know, I'm the owner of the Drip Bar in Portsmouth, a medically overseen IV therapy and wellness clinic, and founding member of the American IV Association. We have over 100 locations around the country and Canada and continue to expand with over 600 in development. Our clinic operates under robust medical oversight. We participate in a National Medical Director program, and our protocols and menus are developed and reviewed by a multidisciplinary team that includes an oncologist, a doctor of pharmacy, an osteopathic physician, and nurse practitioners. All care is delivered under standing orders, evidence-based protocols, and strict safety standards. In-house, I have paramedics, an advanced EMT, and registered nurses, all who are incredibly skilled at what they do. In New Hampshire, paramedics and advanced EMTs are licensed by the New Hampshire Office of Emergency Medical Services under RSA 153A and associated administrative rules. Their licensure requires formal education, supervised clinical training, successful completion of cognitive and psychomotor examinations, and ongoing continuing education to maintain certification. Critically, intravenous access and IV medication administration are mandatory competencies for licensure at the paramedic level, and we're authorized for advanced EMTs. These skills are not optional or employer-based add-ons. They are required, tested, and evaluated as part of the state and national certification process. Established IV access is central to the paramedic scope of practice in New Hampshire. Paramedics are trained to initiate and manage IV access, administer IV fluids and medications, assess patients for contraindications and complications, maintain sterile technique, recognize and respond to adverse events. They are entrusted to perform these skills in high acuity, uncontrolled environments, including cardiac events, trauma, dehydration, allergic reactions, and other medical emergencies, much like Matt just said. Often without the supportive structure found in hospital or clinics. By contrast, IV insertion is not a universally required component of initial nursing education. While many nurses become highly skilled at IV initiation through post-licensure training, IV placement itself is learned after graduation through employer orientation or continuing education, rather than as a condition of licensure. All of my nurses are highly skilled at IV administration and are part-time per diem with me and also serve as ER, NICU, labor and delivery, and ICU nurses as well. From a patient safety perspective, it is inconsistent to allow paramedics to initiate IVs in emergencies in New Hampshire, but prohibit them from doing so in controlled, elective, wellness-based environments where medical oversight, protocols, and informed consent are already in place. I therefore oppose this bill, but I'm also open to amending it, much like these gentlemen who are much far smarter than me and more well-suited from a medical perspective. But I do think it's important that it takes a lot of, there's a lot more that goes into it, and certainly education for the person that's proposing it, who is pretty sad that she's not here to listen to this testimony. But that's all.
Thank you. Perfect timing. Representative Kesselring.
I didn't catch it.
Thank you, Mr. Chair. I'll make this question easy. Do you feel that it would be deemed easier to make it that all of these people providing the IVs have some type of medical oversight?
Absolutely. I 100% agree with that. And I also think, too, that there are certain phlebotomists, it is illegal for a phlebotomist to actually deliver anything into blood. So that is something that is a law.
Representative Weber.
Thank you, Mr. Chairman. I have actually a question of the chair, if I may.
Okay.
I was wondering if it would be possible to have our researcher check and see if there is anything in our laws that sets out who may start an IV, because I think that's a threshold question that at least two of us want to know. And my quick online survey says that in New Hampshire, any licensed medical professional, including a medical assistant with doctor supervision, can administer IV therapy in New Hampshire. But it doesn't give me a site, so I don't know where that came from or how accurate it is. So I would love to have, if it was okay, for you to ask our researcher to give us perhaps a very quick memo on the minimum requirements
For someone who's
that are all
prescribed an IV.
yeah,
Okay,
for what is already on our books, because listening to Representative Wade, I was kind of gobsmacked at the idea that anybody who didn't have some one of the many licenses that we're talking about could just go out and do that. And the idea that I might put out a shingle at the bottom of my driveway saying Lucy's IVs, y'all come, is kind of anxiety producing.
To all of us.
That would be really helpful.
Yeah.
Sure. Anyone else? Representative Palazov.
Thank you, Mr. Chair. So in line with previous discussion, my understanding that your company employs licensed professionals, but can you name any competitor in New Hampshire who you know that their staff is unlicensed?
No, I cannot. It was actually blew my mind that it would be something that existed. I will say that this industry has, like she said, has been growing rapidly, especially post the pandemic, where more and more folks are focused on proactive and preventative healthcare. So I have seen in my research when I was on the franchisor side, selling these franchises, that there were competitors out there that looked like they had, you know, a lounge chair that you put outside, and their outfit didn't look like it was very that there was a lot of regulation to it. I agree with regulating this industry, and I think it can be a good thing for everyone and keep everyone safe so that nothing ever happens like what did in Texas. And I don't know the full understanding of how that did happen, but
Okay, I'm seeing no one else. Thank you. No one else has signed up to testify on this bill. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on HB 1321 and open the public hearing on HB 1368. And recognize the prime sponsor, Representative Opel, I'm sorry, from Grafton District 9. Thank you for your patience, Representative Opel. There you go.
Thank you, Mr. Chairman. Excuse me. Chairman McDonald and members of the House Health, Human Services, and Elderly Affairs Committee. First of all, I'm glad Ways and Means only has words on either side of the ampersand. That's a mouthful. But thank you for this opportunity to introduce House Bill 1368. For the record, I am Thomas Opel, representing Grafton District 9, comprising the towns of Canaan, Dorchester, and Orange. And I will be the first to admit that I am the farthest thing from an expert on healthcare. But I introduced House Bill 1368 after watching the community health center in my district, in my town, struggle, and seeing that pattern duplicated across the state. The members of this committee are far more familiar with the issues of access to primary and preventative care and its affordability when it is available. Again, especially in the rural areas of our state. And you're also, I know, aware of the impacts of the changes at the federal state level to Medicare, Medicaid. But while I'm not an expert, and I have seen firsthand at our community health center, where I am both a patient and had the opportunity to help out with scheduling for a brief time because of circumstances where they just needed help. And I've also heard it again and again from my constituents. That anecdotal evidence is further reinforced by a survey done in September 2025 by the Public Health Council of the Upper Valley. Problems with accessing primary health care was the top problem identified by respondents in this community. 42% said they had either issues themselves or with close family or friends in accessing care. And 3/4 of those reporting those kinds of issues said they could find no provider who was accepting new patients, and 68% said the wait times for an appointment were simply too long. Close behind was access to dental care for adults, with 39% reporting difficulties, and I know I don't have to tell the members of this committee the health impacts of bad dental care. Nearly 6 in 10 said the cost of health care and health insurance had gotten worse in the past few years, and 54% said access to primary care had gotten worse. The dental practice at our community health center had to shut down for a period of months when it lost its only dentist. Fortunately, it was able to find new dentists and reopen, but the demand began to overwhelm the small staff, and that's when the director, who's a friend, asked me if I had some time to help out, just answering phone calls and dealing with trying to catch up with the overwhelming response from people who wanted to become patients. In contacting individuals to let them know of appointment openings, or in fielding calls from those looking for emergency care because they were in severe pain, I found myself again and again, either face-to-face or on the phone, dealing with people who were literally reduced to tears because of their pain, because of the fact that they were just so grateful to be able to see somebody. In attempting to develop this legislation seeking a study, and my understanding is this may not be the only bill that's focused on this area, but I did consult with providers and experts in my area. I will also say that I'm sure that there are additional areas that I may have overlooked, or areas that are outlined in this bill that may need to be either included or unincluded or refined in some way. So, and I'm happy to work with anybody on the committee to accomplish that. And as I say, I'm not an expert, but I'm happy to try and answer any questions that I can.
If I could start off with a question. All study committees and commissions have a very noble purpose, and that's beyond question. The challenge is staffing them, finding people to be willing to serve on them. Do you have anyone in mind that might want to serve on this committee?
Well, I'd be happy to.
Okay.
I honestly, Representative, I don't. I'm assuming that it would be members of this committee who would be, some members of this committee who would be most suited, since you're more familiar with the topic. I'm a first-term rep. My experience, frankly, is related to what I've seen as both a patient and in the short time of trying to help my community health center. But I know there are community health centers across the state. In some cases, they're closed. They're creating all sorts of issues. I know for a time, Dartmouth Hitchcock, which is very close to where I live, most of the doctors there were not accepting new patients, particularly in the primary care area. So and as you all know, you don't need me to tell you, but the truth is this is obviously both a health issue, a moral issue, frankly, but it's also an economic issue, because if people can't get care as they're going through their lives and they end up with more severe, more critical issues, they end up going to emergency rooms at a far higher cost. That has an impact on uncompensated care. It has an impact on insurance rates, and the ripple effects go on and on and on. So I hate to think in just terms of economics, but there is an economic component to this as well.
Sure. Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. And if you don't want to answer it, it's perfectly fine. I'm just going to ask anyway.
I'll do my best.
One of the things we have been hearing, and one of the things that happened subsequent to our bill filing deadline, is the rural health transformation grants. And I wonder if the institution of the rural health transformation grants make any difference in your thoughts about this bill, or what it ought to look at, or how it ought to do, or whether it's needed.
And honestly, Representative Weber, I don't know the answer to that. I do know that, obviously those grants came, the grant came through after our filing deadline. I do think, I'm not sure exactly how that structure is going to work, or who's going to be staffing it. And I do think, maybe it's because I've spent a good deal of my career in electoral politics, that I think having elected representatives of the people, senators and representatives, sorry for the mention of the other chamber, who are more responsive, frankly, to their constituents. I think having some of us in that capacity would be helpful.
Anyone else? Representative Lamontagne.
Thank you, and thank you for taking my question. I worked in a community health center for years as WIC director, so I'm very familiar with the struggle to stay in business. But I feel that we already know a lot of what the problems are. The last two bills we've heard, one was very much, that there's a lot of pressure to deliver services and highly reimbursed interventions, and then also this fee for service new model of, there's no insurance at all, and primary care is not reimbursed. But do you feel that at the state level, we can solve these problems ourselves? And do we not need to be focused more nationally on how we can ensure that primary care is reimbursed appropriately for the tremendous role it plays in our healthcare?
Well, Representative, as you know, I'm a co-sponsor on your bill regarding a federal national answer, and I absolutely believe this is a national problem. That being said, I also think that any journey begins with the first step. So I'm sort of willing to try and tackle this at every level. And I think having us take a look at it, we are the first in the nation primary, the first state to do a lottery. Why not take a shot at primary care?
Anyone else? Representative Drew.
So, as I'm sure you're aware, we already have a legislative commission on the interdisciplinary primary care workforce. In fact, in this bill, it's part of this committee's job to analyze the work of that commission. What would this committee do that's different from the work that the commission is doing?
Well, thank you for the question, Representative. And I've had the opportunity to attend a couple of that organization, that commission's meetings. What I came away from that experience is, again, I think having a committee, a study committee made up of elected representatives. There are some elected representatives on that committee, but it's just my view. Sometimes when you're in the middle of the fight, so to speak, it helps to have a different perspective, and I think the Legislative Study Committee to me was an opportunity to add to that perspective. So,
anyone else? Seeing no one else, thank you.
Thank you.
Also signed up to speak is Christine Stoddard from the Bi-State Primary Care Association.
Good morning. For the record, my name is Christine Stoddard, and I am the Senior Director of Public Policy at Bi-State Primary Care Association. We represent community health centers in New Hampshire and Vermont, and the sponsor is correct. Community health centers and other primary care providers are suffering, and there are many reasons why that is the case. And I agree that something needs to be done, but I don't know that adding another study commission or committee is the answer, given we have an Health and Human Services Oversight Committee that meets regularly, and we also have the Interdisciplinary Workforce Commission. I haven't had enough coffee today. So one of the main reasons why the community health centers are suffering is because their reimbursement is inadequate. Their federal grants, and the health center in the sponsor's district is not a federally qualified health center, so they do not have access to the federal grants that support federally qualified health centers. So I want to make sure that you know that difference. So they rely solely on grants and patient reimbursement to pay for their services. So the federal grants that FQHCs rely on haven't changed since 2015, which means they're actually losing money if you consider the time value of money since 2015. The other issue that we encounter is that our Medicaid rates are going to go down substantially because of the changes that were made at the federal level. Our patients are going to lose their Medicaid insurance, which is one of their biggest payers. And also, we are going to see, and we already are seeing, more people lose their health insurance, and that includes commercial insurance. Our health centers treat about 35% commercial insurance and 35% Medicaid, so it's about even depending on, or statewide, but depending on the health center that you're looking at, their payer mix may look very different than that. If you look at Amoskeag and Manchester, their patients are insured by Medicaid predominantly. If you look at Coos County in Berlin and Gorham and Colebrook, they have a lot of Medicaid and a lot of Medicare. If you look at Ammonoosuc and Littleton, they are predominantly commercial and Medicare insurance. But the bottom line is that the changes at the federal level are hurting your constituents and their healthcare providers, and we would love to work with you to advocate for changes, including the Medicaid work requirement that I know you've heard a lot about over the past 6 months. But those are the types of policy changes that negatively affect primary care. And I'm happy to answer any questions if you have any.
Okay, thank you. Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So in the bill, the different duties for the committee listed, and I see that Representative Opel did his preparation with specialists, and he lists reimbursement that you covered in your testimony, but he also lists several other issues like impact of electronic health records and different prior authorization, administrative burden, and volume constraints, and possibly some other reasons why PCPs are struggling. So in your experience, are those valid concerns? And besides reimbursement, what are other major factors that negatively affect PCPs in New Hampshire?
Thank you for the question. All of his concerns are valid, and they exist. One of the other concerns that we would raise is the state loan repayment program. It's the #1 recruitment tool that rural healthcare providers have in the state of New Hampshire, and the legislature froze it. So right now, we cannot access state loan repayment dollars to recruit and retain qualified primary care clinicians. It's also available to emergency room doctors. So critical access hospitals can't rely on the state loan repayment program right now to recruit and retain qualified clinicians. I think that all of these ideas are valid. If it were up to me, if I were a legislator in your seat, I would take a look at what already exists in terms of commissions and committees and divvy up where you want this information to go. Because DHHS actually does a great job on in their health professions data center. They publish a report every year as required by statute under 126T. That really digs into why there are primary care practices suffering and where the provider vacancies are, how long people plan to practice before they retire. There's a lot of information out there. It's just sort of spread amongst various committees and commissions.
Thank you. Could you send us, the committee, the link to that resource you just mentioned?
I'm happy to.
Anyone else? Representative Tellez.
Thank you for taking my question. So, the Legislative Commission on the Interdisciplinary Primary Care Workforce, do you think that what is desired here, which is a report, do you think that could be asked of the existing commission, given that some of the data already comes from those members?
Thank you for the question. I think yes. And if we needed to add more experts to that commission to accomplish this, we could do that, including UNH. That might be someone that we would look at, like Deb Fournier, to add. She's going to love me for saying a name in a committee hearing. We could look at adding someone from UNH who works in this area to the commission to get at why this reimbursement and the other issues that he outlined exist.
Anyone else? Representative Weber.
I just had a quick question. It's fine if you don't have it, but did you pass out written testimony at the beginning?
No, I wasn't planning on testifying.
That's perfectly fine. We sometimes get stuff lost and stuck, and it's often here at this corner. So I wanted to go and search for it because it's usually my fault if we do get stuck. But you've let me off the hook, so thank you.
May I answer Representative Weber's question about the Rural Health Transformation Funding?
Go ahead.
Let me ask you if you have something to say about the Rural Health Transformation Program.
I do. So that funding cannot be used for primary care reimbursement. It cannot pay providers. It cannot make up for any of the gaps that are created by the One Big Beautiful Bill. It also cannot be used to help people access health insurance. So we currently have a very limited navigator program which helps people access health insurance and learn about health insurance. That program was also defunded by Congress. And it is very clear that that rural health transformation funding cannot be used to mitigate that. It can be used to buy technology like AI scripts. It can be used to buy equipment like blood pressure cuffs, but it cannot be used to help healthcare organizations stay open. You're welcome.
Anyone else? Saying no one else, thank you.
Thank you.
Also signed up to speak is Jason Aziz from the New Hampshire Insurance Department.
Good morning, Mr. Chair.
Morning. It's still morning. Yeah.
Still, I know. I had to check. And nice to see your beautiful smiles today. Thank you. I did want to laud the bill's sponsor because at the insurance department we evaluate and prioritize primary care access for all our citizens, especially in the commercially insured market. The position that the insurance department has on this bill is rather neutral. I just wanted to point out that There's a plethora of work and reports that we produce each year on primary care access, especially with regards to a reference in section 1 of the bill looking at time and distance for our citizens to access primary care. We've done a lot of work in that area, a lot of work with the federal government and CMS. Importantly, CMS recently deferred to the New Hampshire Insurance Department to evaluate time and distance standards for the QHPs, which are qualified health plans, part of the marketplace plans, because our network adequacy review approach and our standards are much more stringent. So we had to take a stringency test, which we passed mightily, that shows that the New Hampshire standard to assess, evaluate, and regulate time and distance standards for at the county level and many other demography levels is more rigorous than the federal standard. We use an empirical approach to do that, a claims-based approach, which is important and unlike the federal standard. And a claims-based approach, well, I call it the empirical approach because it's really what the exposure to primary care access for our citizens is and was in the previous plan year. And that's important because we're one of 4 states in the nation that actually do that. The other states all rely on self-reported, carrier-submitted networks and don't really affirm whether or not citizens in our state met with a real provider receiving a real primary care service in one of our counties, and that's important to us. So I wanted to point that out. Regardless of what happens with this bill, I think it would be important to make this committee aware that a plethora of data already exists looking at that, and you might benefit from having that awareness. Thank you. I'm happy to take any questions.
Thank you. So the department is not taking a formal position on this bill, is that correct? Or
in light of your initial question and comment, you know, we feel that maybe creating an awareness in this committee about that information might influence your decision on whether or not you think a legislative study commission could advance the understanding of this enigma in our state.
Okay, thank you.
That's how I see that.
Representative Weber.
Thank you, and thank you for taking my question. I'm wondering, plumbing the depths of my own ignorance, you've talked about the claims-based approach, and my question would be, claims are submitted after somebody's actually received a service, which I think you alluded to because it's based on reality with the service. How does this approach assess the people who haven't submitted a claim because they haven't been able to access any service? So I guess my question is, if this is focusing on what's there, how do we focus on what's not there?
Well, the first part is creating a scheme statewide to ascertain whether, the term adequacy is the key part, and adequacy is defined in our statute and our administrative rules. What is an adequate network? And as a note, it's not just primary care that we review services for. It's a broad continuum of over 147 services. Primary care reflects about 25% of those. So to your question, the rigors are part of that instrument that you've asked about, but the other part are elements in our statute. We have an arcane statement in our department that you can't manufacture providers. At least right now you can. And I laud and listened with great interest about the previous testimony related to the frustrations about attracting providers to our state. And I do indeed agree with the bill sponsor's comment about it's about economics. This is about health economics and the interest that a new medical provider might have to set up shop in a rural part of our state. So we review our time and distance standard compliance throughout the state by county and by zip code, 2 or 3 reference zip codes in each county that are reflective of population density centers in those counties. If it's noteworthy that if a plan's network fails in any area for any service to meet the network adequacy requirements specified in our law, INS 2700 is our set of administrative rules that specify those time and distance standards that are stratified by service type and by urban rural status. If they don't meet that, then the provision in our rule specifies that they have to pay that provider and allow for cost sharing out of pocket payments for the patient at the in-network rate. And there's merit in members of this committee being aware of that. We can't fine them or force them to leave the state for business. That wouldn't be good for our citizens. So that is the remedy that is in place right now. And we see that works as a financial incentive for plans to expand their provider contracts when in fact they don't meet that. And that's one of the mechanisms that we use. We try to have a curative approach when they don't pass, in other words, fail any one of those time and distance standard evaluations for any given service. We have a reference file. It's a massive NHID resource file that lists all of the providers in the state that have met the time and distance standard in any county for any service. It's very comprehensive. We send that to the carrier. In fact, they have public access to it. And they can find when they can add a provider to their network that will fill that gap. And that's generally the mechanism that our department uses to handle this issue. One thing that's noteworthy about it is that we don't look so much at primary care as providers. We look at primary care as healthcare services, service categories. There's an organization in New England called NESCO. They sought to define what does primary care mean. And they actually have a hybrid approach to do that based on provider taxonomy code and service code. Our approach to network adequacy looks merely at services because we feel that when there's unmet demand, we appreciate the fact that non-physician providers like physician assistants and nurse practitioners can provide these services, these healthcare services to our citizens, not a title or a specialization license. And that's really important, and that's, I think, born out of necessity. So I know that's a lot. I appreciate your time and your smiles, and I welcome any other questions.
Any other questions? Seeing no other questions. Okay, thank you very much. No one else has signed up to testify on this bill. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on HB 1368. The next hearing is scheduled for 1 p.m. on HB 1782 FN. We will be in recess until then.
want to find out if I would be winded, so I'm just not doing it.
It definitely gave me a wake-up call.
It's 4 flights of stairs.
You're not winded here. I did
Yeah,
it.
that's true.
I went down and I was fine, so now I gotta go from back down.
Hello.
Okay, I'd like to call us back to order for the afternoon session of the Health and Human Services and Elderly Affairs Committee. The next bill up is 1784, is it?
1782.
1782. That's it. And the prime sponsor is not able to be with us this afternoon, but ably filling in for her, ably filling in for Representative Boschman is our own Representative Weber.
Thank you, Mr. Chairman. I am Lucy Weber. I represent Cheshire 2, which is the towns of Surrey and Walpole, and it's a pleasure to be presenting a bill to you today. House Bill 1782, relative to access to rural maternal health care, directing the Department of Health and Human Services to develop a rural maternal health care delivery pilot program. I am introducing this on behalf of Representative Boschman, who's the prime sponsor and who is not able to be here today, but Representative Boschman has communicated with me and asked me to relate to the committee that, in fact, much of the work that was contemplated in drafting this bill is now actually going to be going forward under the Rural Health Transformation Grant. So various sponsors, various stakeholders decided that perhaps they didn't need to go forward with this bill. But I need to make sure that I mention on behalf of Representative Boschman the New Hampshire Perinatal Quality Collaborative, which worked very much collaboratively on this bill and is very concerned, as we all are, with access to maternal health care delivery. So with that, I am going to conclude my testimony and hope fervently that you don't ask me any questions, because I've given you all the knowledge I have on this particular bill, if not the subject.
Okay, well, thank you.
Thank you.
Okay, so what I would like to do at this time is, obviously, we have no one else has signed up to testify or expressed interest in this bill, by the way. But I will formally ask, does anyone else wish to testify on 1782? Oh, you would? Okay. Please come forward and give us a pink card.
Good morning, Mr. Chairman and members of the committee. Excuse me. My name is Jennifer Smith, and I'm the Legislative Director for the New Hampshire Insurance Department. We just wanted to come forward today. We are neutral on the bill that has been introduced, but wanted to point out a technical defect should the committee decide that there is merit and they might want to move it forward. In Section 2 of the bill, it directs the Insurance Department to conduct an audit of all Medicaid providers to ensure contracts and reimbursements for certified nurse midwives and certified midwives comply with state law. The department has no jurisdiction or regulatory oversight over Medicaid programs, and we would be ill-equipped to conduct such an audit. Additionally, the department was never contacted to provide a fiscal note on the bill relative to that section where it would ask us to do that, but the department would need additional money to be able to fulfill that part of the bill should it go forward. So we just wanted to point out those two things to the committee for their consideration.
Okay, thank you. Any questions for this person? I'm seeing none. Okay, thank you. Okay, based on the prime sponsor's sentiments as expressed by Representative Weber and in conversations with Representative Weber, what I would like to do now is close the public hearing on HB 1782 FN and open a brief executive session on that same bill, 1782 FN, and move that, make a motion of ITL. And Representative Markell?
Yes, I second the motion.
Okay, is there any discussion? Any?
I need to get the proper papers.
Sure. Oops. Give the clerk a couple minutes to get situated.
Sorry about that.
No, that's okay. You didn't know this was coming. And again, just to speak to my motion, eloquently stated already by Representative Weber, the Rural Health Transformation Grant has addressed the work that was intended for this bill, and to address the insurance department. I'm sure one of the reasons that they had not been approached is because the prime sponsor saw this coming. We did get a fiscal note since. In fact, I think we just got it today. It does not indicate any expenses attributed to this bill. So
I'll fill out the bill title later.
Sure, Representative Weber.
I think the only other thing I wanted to add is that one of the things that we saw in the Health and Human Services Oversight Committee recently, and I can't remember which month it was a report on the expansion of the Medicaid benefit from 1 month, the maternal benefit, and I keep wanting to say postpartum benefit, but it's just, they extended the coverage under Medicaid from 1 month to 1 year, and we were presented with some pretty impressive statistics indicating that that change had had a significant effect both in physical health and behavioral health and dealing with postpartum issues and also addiction issues and support. And so I think that having done that was a really great thing in terms of maternal and infant health. And I'll just plunk that in. It doesn't solve all problems, but it was a great step in the right direction.
Great. Anyone else? Okay, the clerk is ready. I'll ask her to call the roll. The motion is ITL on HB 1782 FN.
Representative Mazer,
Yes.
Representative Delanis, yes. Representative Copal,
Yes.
Representative Palazzo,
Yes.
Representative Drew,
Yes.
Representative Markel,
Yes.
Representative McGrath,
Yes.
Representative Kesselring,
Yes.
Representative Weber,
Yes.
Representative Woods,
Yes.
Representative Palmer,
Yes.
Representative Tellez, sorry about that. Representative Lamonte,
Yes.
Representative Hartnett,
Yes.
Representative Lucas,
Yes.
and Representative McDonald.
Yes.
Okay. That I just, that's a no. $16
16 to 0.
to 0. Motion passes.
Is there any objection to consent? Okay. Okay, we'll put this on the consent calendar. And with that, I will adjourn the executive session. We'll reconvene at 2:30 for the other bills that we have noticed.
2 o'clock.
We still
have another
hearing.
But the executive session is at 2:30.
Yes.
Right.
Right.
Oh, I'm sorry.
So we'll reconvene the executive session at 2:30. Right. We will, but we will be in recess until 2 p.m., at which time we will hear HB 1372. So we'll be in recess until then.
Sorry, I will try and keep hold of the plot.
Who moved it?
It was Representative McDonald.
Okay, I'd like to reconvene the meeting of the Health and Human Services and Elderly Affairs Committee. We have one bill left to be heard today. It's HB 1372. And to present the bill, I'll recognize Representative Joe Sweeney from Salem.
Thank you, Chairman McDonald, and thank you to the members of the committee. For the record, Representative Joe Sweeney, I represent Rockingham District 25, which is the town of Salem. I really appreciate the opportunity to introduce House Bill 1372 today. I have passed around written testimony, but I'm going to go a little off script from what the written testimony has, just for clarity for folks that are trying to follow along. You're not going to match up my words exactly with what's said on the paper. The bill is introduced, establishes a commission to study the feasibility of reestablishing a state psychiatric hospital for adults with severe and persistent mental illness. I know there are a lot of stakeholders who are here behind me looking to speak on the bill. I think as drafted, this bill could use some improvements to expand the scope of the commission. The goal and the intent of the bill is to make sure that our delivery of mental health services and how we're interacting with folks that need help from the state, that need these services, are getting it in the best way possible, and that the system is built to not be overburdened. Now we're seeing ER rooms over capacity with folks, county jails, a lot of strained resources outside of what we would think of as the mental health sphere, and the mental health sort of community has just been strained by the current system that we have for mental health. And I want to make sure that it feels like a topic that comes up every budget cycle for how we're building the system and how we're running it, and we never have the time during the budget process to really dig in and look at how we operate as a state when it comes to mental health and beds, and who is stuck in a bed because there's not community resources out there. So I will be happy to propose an amendment to this commission that would add some of the stakeholders behind me to the commission to increase the work of what the commission can do, and also add a bullet point to examine existing community resources and the scope that existing community resources have, and how we can better improve upon that existing system, as well as the other areas that the commission lines out, so we can have a real full up and down review of our existing mental health practices in the state of New Hampshire, so that we can hopefully build a better system for the patients and for community members in the state of New Hampshire. So that's where I'll end my testimony. I'm happy to take any questions, and I know there's a lot of much smarter people than I, based on the 10-minute conversation I had before the hearing, that are also here to speak to you as well.
Okay, thank you. Representative Hartnett.
Yeah, thank you, Mr. Chairman. Thank you, Representative Sweeney, for taking my question. If I understand your remarks correctly, you're willing to, in a sense, modify the scope to look more broadly at mental health services in the state?
Yes.
Okay. Follow up. And you're very willing to change the commission membership to include psychiatrists, representatives from the community mental health system, the state hospital, community health centers, maybe homeless providers. I'm just trying to stay close to your.
Sure, I think there's a representative here from NAMI who might be a great addition to it as well.
Yep.
And if there's anyone else here that's here to testify that wants to be added, I would be supportive of that. If not, the goal of this isn't to have a commission that has one offset in mind and one end goal, but let's bring as many of the stakeholders together as possible and have as thorough a review of our state as possible.
I'd be happy to work with you on the amendment.
Thank you.
Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. So can you give us some background what you want eventually to see improved, and how we handle mental health, maybe especially around law enforcement, but also in your written testimony you write that you are not happy how it was done before. I think you call it a failed approach of the past. So in your view, like, what exactly was broken back then that we cannot just exactly move back to past practices?
Absolutely. Thank you for the question. So I think whenever we start talking about this subject, maybe in our minds, maybe when we close our eyes, we think of the horror stories of the 1950s, 1960s, the Nurse Ratchets of the world. I do not want to go back to that. I don't want to go to that failed system and that failed approach. There's great testimony, again, from NAMI that they'll talk about, in which we have folks that are taking up beds in the existing New Hampshire hospital that because there's not enough places for them to go when they're going to speak much better than I will, but essentially they're stable to go back into society in a community setting, but they're not able to because we don't have that community setting set up. So they're taking up very expensive beds at New Hampshire Hospital, which then creates another backlog of bed space for folks to utilize. And so that's what this commission will be fully examining, how we can build that better system for all involved.
Representative Weber.
Thank you, Mr. Chairman, and thank you very much for taking my question. It's very much built on what you just said about the people who don't have an appropriate community setting to go to. So would you be willing to have added to the charge of the commission looking at what is available for community supports? Because just getting people out of the hospital without the appropriate level of support isn't working for anybody. And could we also add a discussion of funding sources for that to the charge?
I'd be happy to include that in the amendment. I think there are folks that need more services than can currently be offered, and then there are the folks that need less services that can currently be offered, but we don't have either. We're kind of stuck with what we have, and I think examining not only the funding for more services maybe, but also the cost savings to the state for some of those more limited services that are still limited but would cost the state less than the $1,600 a day New Hampshire hospital bed cost.
And to follow up, and then the other thing that I had in mind, would you agree that funding or implementation, because who knows how you would do it, of community housing which has services attached would also be something that would be studied?
I absolutely agree, because I think we might be able to find savings in what we're currently doing.
Yeah.
And that would help fund other services to take up the slack.
Thank you.
So yes.
I'm hoping that Representative Hartnett wrote all that down.
That'd be great. And I again, just to stress to that point, I want this to really be that comprehensive review of what we're doing and how we can get to a better way for folks.
Thank you.
Thank you.
Anyone else? Representative Tejas.
Thank you, Mr. Chairman. Thank you for taking my question. So, I know this is not the first time it's been proposed that there be study of like our mental health system service provision. There's a couple commissions, just quickly searching on committees we've had in the past. A couple commissions. Are you aware of what came of those previously?
I can't say that I am.
And I believe there's other groups in existence still, but I can't name them off the top of my head. So,
Anyone else? Seeing no one else. Thank you.
Thank you very much.
Also signed up to speak is Cynthia Bibonis from the New Hampshire Hospital and Department of Health and Human Services. And I don't think the other person, is there a separate card for this other person, or?
No, I can come add my name.
Okay. Oh, okay.
So we just weren't sure.
Great, thank you. New Hampshire Hospital and DHHS.
Good afternoon. Thank you, Chair and members of the committee. I am Jenny O'Higgins. I'm the Legislative Liaison for Behavioral Health at DHHS.
And I am Cynthia Bibonis. I'm Chief Community Integration Officer at New Hampshire Hospital, and
my responsibility is discharge planning at New Hampshire Hospital.
So DHHS is not here to take a position on House Bill 1372, but our role today is to provide you some context on the mental health system priorities and to share some data that will help inform best practice in care delivery. So I'm sure many of you are familiar with DHHS roadmap, our priorities, our priority goals. So we have a new roadmap out from 2025 to 2027, sort of talking about where we are most focused as a department. And you may also be familiar with the Mission Zero work to reduce ED boarding. So the department has had a really large focus on reducing the need for emergency room care and inpatient care, and instead a focus on community-based mental health care, which is both less, costs less, and is more effective in many situations where people are getting their care in community. And rather than expanding our inpatient capacity. So our community-based services include things like mobile crisis teams and crisis stabilization units. It includes increasing our community behavioral health clinics. And they are, these are options that we know are proven to reduce unnecessary hospitalizations and emergency department boarding. And so that's why that focus has been really in those areas. We know that individuals recover faster and maintain stability when they're supported close to home with family and local resources. And that community care can help to avoid some significant capital and operational costs, including buildings and staffing for a new psychiatric hospital and reducing that taxpayer burden. And again, those investments are also meant to prevent crises more upstream before requiring inpatient care, and they help to align with that Mission Zero work and the DHHS roadmap success in reducing that psychiatric boarding. So that is kind of our focus of where our goals have been for the department and for our mental health system. And we'll give you some data on our current track.
Yeah, and I'll just add to that. Currently, over half of the 185 beds at New Hampshire Hospital are occupied by stable patients who no longer require our level of care. And that's not a new situation. It's been that way for a number of years now. These patients are stable and ready for less costly community-based care that is not necessarily available when or where it is needed in order for them to leave the hospital when they're ready to leave. Those stable beds are not billable beds, so they're all supported by general funds. Adding a new state psychiatric hospital risks diverting resources away from community programs that need it in order to keep people well and out of crisis and out of inpatient care. Inpatient care should remain the last resort, not the centerpiece of our system. Over-reliance on hospitals can lead to higher costs and poorer long-term outcomes. New Hampshire has already seen measurable improvements through Mission Zero, shorter ED wait times, expanded community capacity, and zero wait lists on certain days in this last year. Continuing this trajectory means strengthening community infrastructure, not creating expensive inpatient facilities that may duplicate existing services. While HB 1372 seeks to study inpatient expansion, DHHS emphasizes that the most effective and fiscally responsible path forward is investing in community-based care consistent with our roadmap and Mission Zero priorities. I'd just like to finish by saying that the wait lists for entry into New Hampshire Hospital is usually less than 30 and often less than 10 people waiting in emergency rooms, relative to the 85 to 100 people in the hospital at New Hampshire Hospital right now who are ready for discharge but can't get out. So we could eliminate that ED boarding pretty quickly if we could take care of the backdoor issue.
Thank you. Representative Weber and then Representative Hartnett.
Without trying to get into the work of the commission, if one was to be established, but so we could draft the appropriate things into the charge of the commission. If you were thinking about the most needed community-based supports at this point that people are waiting for, what kind of supports are really needed? Is it dedicated housing with staff, or is it more support for people in their own houses, or what is it that we need the most of, or what's the range that we need to include to be studied?
We're working really diligently on having that level of data about the patients waiting at New Hampshire Hospital, but what I can say is it's across the range of levels of care that are needed in the community in order to help people get out of the hospital when they're stable and ready to go. I can summarize that the longest unnecessary bed days for individual patients tend to be those who are waiting for residential placement that has supports in place, but collectively other unnecessary bed days pile up for things waiting, like waiting for an intake appointment perhaps that might be able to happen sooner if the community mental health centers had the resources to hire more staff and the funding necessary in order to put those things in place.
Representative Hartnett.
Thank you, Mr. Chair. Thank you for taking the question. I may be asking the same question that Representative Weber asked in a slightly different way. My understanding is there was a period 30 plus years ago where mental health services in the state didn't face the same challenges we do now. And I wondered what, if anything, we could take from that experience and apply it to today. In other words, what services were we offering then that made a difference? I think it's a little bit of a piggyback on the question you were asking.
I think that's a pretty complex question. I have been working at the state hospital as a psychiatric social worker for 25 years, so I do remember a time when we didn't have a wait list to get in the hospital and we didn't have this level of challenge getting people out when they were stable. But I would defer that question to maybe one of our representatives here from the Community Mental Health Center, because I think they have the experience to speak to what was available out in the community at that time.
I do think additionally we have seen an increase in need over time, and so there is a change in that as well, where more services are required in some ways, but that we know that community-based care needs to be built up and make sure that people have that kind of access to the treatment that they need when and where they need it, and that will help us to reduce the crisis and the needs for more costly and care inpatient. I do just want to say too that we're happy to work with the sponsor behind the scenes to talk through what commissions are existing that look at the mental health system, the 10-year mental health plan, and sort of where we're at with reporting out on those goals, and talk through these priorities to see if a commission with a different focus is necessary, or if we sort of have the information required to focus on the decisions and priorities we've set today.
Representative Kesselring.
Thank you, Mr. Chair, and thank you for taking my question. I guess this question would be to both of you, because you mentioned the roadmap and you mentioned data. So how is that data propagated, or how do you get this information that you could give us an informed information for the committee?
Sure. So we have the 10-year mental health plan and the DHHS roadmap, and behind those documents, they're putting forward recommendations, right? But how those recommendations come to be is informed by that data. So we look at how many people are waiting for care and how many people are being served to try to figure out where there is a gap and where the need is highest. And then when we have programs that have intensive outpatient wraparound services prior to people being in crisis more upstream, we see a reduction in need on the crisis side of things. So we know that if we invest there, where it's more cost effective, we also then reduce the higher cost need for the crisis and inpatient care. And that's why our priorities have been focused in that area. But we can provide the committee with those existing plans to give you a sense of our roadmap of where we're headed, and then be able to answer any questions about what else might be needed.
Follow up.
Thank you for taking the follow-up. So I get the roadmap is there, but where's the data that's propagated from what you've done in the roadmap? Where's the stuff that you've accomplished?
We can provide that.
Representative Lucas, did you have your hand up?
Yes, thank you. Thank you, Mr. Chair. Thanks for taking my question. Just curious to know if there are demographic differences. Would it be important for the commission to include folks who have expertise in different age groups, behavioral health for teens and adolescents, behavioral health for the aging population?
From my experience so far, what I see is that it affects the entire population of people with severe and persistent mental illness. And so, I mean, there are certain specialty areas, but there are so many of them. So for example, I can gather data on how many people are stuck at the hospital in stable days because what they really need is a nursing home, and we can't find a nursing home bed for them. But just as much, I've got other folks who need a subsidized apartment with supports and an ACT team. And so there's so many different types of issues that are contributing to the stable days at New Hampshire Hospital that it's kind of hard to pinpoint one being a significant outlier, except to say that the biggest one has something to do with housing in different arenas, either nursing home, community residents, transitional housing, or people who just can't find apartments in the market that is in New Hampshire right now.
Follow up.
Thank you. Do you know the percentage of nursing facilities that have behavioral units?
I don't know the percentage off the top of my head because I don't know the total number of nursing homes in the state. But there are a handful of nursing homes that have behavioral units, but oftentimes those behavioral units are not equipped well enough to manage someone who has a co-occurring severe and persistent mental illness. And so we do struggle finding placements for people coming out of New Hampshire Hospital who need that level of care.
Anyone else? Okay, thank you. Also signed up to speak is Jeffrey Vedder. I don't think that's the correct pronunciation. I apologize. Is it? Oh, okay. New Hampshire Psychiatric Society. You've asked for 5 minutes, sir, but try to keep it to 3, please.
Certainly, I think much of my testimony is already sort of been covered, so I'm not going to repeat what has. I'm Jeff Vedder. I'm the Chief Medical Officer of New Hampshire Hospital, psychiatrist, but I'm here wearing the hat of representing the New Hampshire Psychiatric Society, not DHHS or the hospital, insofar as the society opposes this legislation as currently written, but welcomes the opportunity to create a platform to talk about this issue that we've hoped to be able to address for quite some time, which is the ability to discharge clinically stable patients from New Hampshire Hospital to the appropriate level of care. So to the extent that there are over half of the patients at New Hampshire Hospital are not able to be discharged, they are not billable to insurance or to Medicaid. These are patients whose care is being paid for directly from the general funds at $1,600 per day. And that is not the best use of our mental health resources, both because from a civil liberties standpoint, we have decided that they are safe to be discharged, and from a public safety standpoint, as well as from the ability to comply with all the regulations and laws and rules that direct us to try to treat these folks in the least restrictive setting possible. So in terms of savings, I do encourage folks to consider the savings of New Hampshire Hospital being able to be at a higher level of billable patients if we're able to discharge patients who are clinically stable for discharge in their weighing of the ability to move forward with other lower levels of restriction and supervision and cost that this committee could potentially look at in addition to a state psychiatric hospital. Also, the Psychiatric Society asked that we consider essentially swapping out the DOC for NAMI New Hampshire as membership on the commission. And the reason for this, to my mind, is having served as Chief Medical Officer in the Department of Corrections, the ability to run a facility like a jail or a prison is very different from the ability to run a state psychiatric hospital. It's a different mindset, it's a different mission, and it's a whole different set of rules that apply. So to the extent that one of the things that we have to recognize is that a state hospital is, let's call a spade, an instrument of state coercion. We are committing people to a facility they do not want care at, to get care that they may not want. And when the people who are running the facility are basically advocating that we don't need more of that, we actually need less of that. So we'd hope that you can help us find a way to do that.
Thank you. Representative Mazer.
Yes, thank you for taking my question. So I believe the prime sponsor said in his testimony that he'd be willing to amend to add to the scope of this. If that were done, would you then support this bill?
The Psychiatric Society as a group has said, and I agree with the group, that if we were to look at amendments that expanded the scope to lower levels of restriction and cost, housing in the community, as well as the membership changes, we would support the bill in that form.
Representative Drew.
Thank you, Mr. Chair. You said that this would be a facility that would be coercive, giving treatment to people who don't want it, but wouldn't this facility also serve the function of separating people who are unsafe to be in the community because of their mental illness? Isn't that the point of having a psychiatric hospital?
Oh, I don't want to talk myself out of a job. Yes, we need to have a state psychiatric hospital, but we have enough beds.
Representative Weber.
And am I correct in believing that there is a difference between having a state psychiatric hospital, which we already have, which is coercive for those patients who didn't want to be there and are there because of a civil commitment, and a secure psychiatric unit which deals with people who are mentally ill and also criminals, which we're also working on.
Right. So to kind of flesh out your continuum, so the secure psychiatric unit in the state prison system is perhaps the most coercive part of the state mental health system. New Hampshire Hospital is below that. About 100-ish of our patients, we think, could be served at a layer or two below that, such as the type of housing that is contracted to NFI, or group homes that the state community mental health centers run, or perhaps even folks who could live in independent housing with a high level of outpatient support, which may or may not be available in their local area. So those are the layers, those middle layers we're talking about, hoping that this commission could have within its purview.
Representative Markell and then Representative Palazzo.
Thank you, Mr. Chairman, and thank you for taking my question, sir. We heard about people who are stable in the New Hampshire hospital system presently. Do we have any information of them, or how many are repeated admissions?
Yes, we do. I don't have those numbers on the top of my head, but if you wish, I can provide that to the committee.
I'd be interested. Thank you.
Yep.
Representative Palazzo.
Thank you, Mr. Chair. Thank you for taking my question. So some people with mental illness are being hospitalized, but isn't it true that some people end up in jail, so they have to be in the care of Department of Corrections? Why do we need to remove them from this commission? Could they still have their input about the ongoing situation?
Thank you for the question. I think it's important to make a distinction between the Department of Corrections for the state of New Hampshire and the county jails. We deal much more with the county jails than we do with the State Department of Corrections as it relates to involuntary emergency admissions, which is the highest volume of the type of patients that, or legal status of the patients that we receive. So DOC is I don't think highly relevant to the goals of this commission, but I do think that it makes sense to have involuntary admissions from the county jails to be part of the considerations of the commission. My advice would be to have them present information and testimony. I'm not sure that they're critical enough to the system to be part of the commission itself.
Thank you. Any further questions? Seeing none, thank you.
Thank you.
All right. Next we have Sheila Mullen. You've indicated 3 minutes. Thank you.
Hi, my name is Sheila Mullen. I'm the community support. Sure. Let me take that off too. My name is Sheila Mullen. I am the director of the community support program at Riverbend Community Mental Health Center, and I'm here today speaking on behalf of the New Hampshire Community Behavioral Health Association. And I thank you for your time.
Could I just clarify? We had 2 cards for you. Did somebody fill out?
Someone, I think maybe Angela filled out.
You're the only Sheila Mullen that's.
I'm the only
yeah.
one.
Okay. Good. Thank you. Sorry, to interrupt.
Thank you. So we are here to respectfully oppose House Bill 1372. We do share the committee's concern about individuals with severe mental illness experiencing repeated crises, boarding FEED, experiencing homelessness, and interactions with law enforcement. However, we believe this bill moves New Hampshire in the wrong direction. New Hampshire has intentionally built community-based services for clients experiencing mental illness that help individuals live, recover, thrive, and be a part of their communities rather than living in large institutions. The model of community-based service it reflects national best practices, federal policy, and it reflects the preferences of people living with mental illness as well as their families. The current system strain that we're experiencing is not due to community care failing, and it doesn't indicate that we need additional large institutions. The real problems that we feel that should be focused on are looking at chronic underfunding. We experience challenges with workforce shortages by low reimbursement rates, insufficient crisis and step-down services in the community, as well as supportive housing options. There's also been a lack of sustained investment in long-term recovery supports. So studying a new state hospital risks diverting resources from solving the problems that exist within the community that may help support clients living in a least restrictive environment. The risk of returning to an institutional model is that large state psychiatric hospitals historically separate people from their families and their communities. People tend to thrive when they have supports, as well as living in their communities of choice. They create discharge bottlenecks, like you've heard from Dr. Fetter and Cindy Babonis, and they cost significantly more per person, while also serving a limited number of people while the system-wide needs remain unmet. New Hampshire doesn't need another institution, it needs stronger community infrastructure. I also think that this bill puts us in a position of increasing stigma. Individuals that live with severe and persistent mental illnesses are far more likely to be victims of crime than to perpetrate crime. People who are living with mental illness want stability, they want housing, they want relationships, they want things that all the other Granite Staters want. They want to live meaningful lives. And so we feel, in closing, that the legislature should focus on expanding community treatment capacity, strengthening crisis and mobile response services, investing in supportive housing and step-down programs, and improving the workforce recruitment and retention.
Okay. Thank you.
Thanks.
Any questions? Wow. Okay. Thank you.
Oh, okay. Thank you.
Also signed up to speak is Holly Stevens from NAMI of New Hampshire.
Chairman McDonald and members of the committee. My name is Holly Stevens. I'm the Director of Public Policy at NAMI New Hampshire, the National Alliance on Mental Illness. I was here today to speak in opposition to House Bill 1372, but did have a chance to talk with Representative Sweeney before this hearing began, and was pleased to hear that he's open to amending the bill to look at the full spectrum of mental health services, as well as adding some additional members to the commission, including NAMI New Hampshire. New Hampshire Hospital, as you've heard, has 185 beds. In addition to that, there are other voluntary and involuntary psychiatric beds at some of New Hampshire's hospitals throughout the state. Through the work of the Mission Zero initiative that you heard a little bit about, this is a mission to end ED boarding. Much data has emerged that has shown us some of the issues within the mental health system. One of those pieces of data is what you've heard about today with the 100 to 115 people waiting at the back door of New Hampshire Hospital on any given day. These folks are medically stable, which means they've been found to be not a danger to themselves or others, so they are safe. They're safe to be discharged to the community. But they don't have any place to go because there aren't sufficient community resources. I attached a chart to the back of your testimony. The orange is the people who are medically stable and just living at New Hampshire Hospital. The blue are the people actively receiving treatment. You've heard that the backdoor problem is costing the state $1,600 per person per day. And if you take that math out a little bit further, it's $160,000 per day for all of those people if there's 100 to 101 people on any given day. Take it out even further, $4.8 million in 30 days that the state is spending to house people that don't need to be in the hospital. That's why we think that this money could be better invested in community resources such as supported housing and other, like the ACT team, which are, more intensive community services to keep people in their own homes if they're able to return to them. We strongly feel that any commission studying these services should minimally include a mental health provider, an individual with lived experience, and stakeholders representing the impacted communities. We would welcome the opportunity to work with the sponsor on an amendment, as well as being considered for, and it sounds like we are being considered for, inclusion in the commission. If included, we would happily serve on the commission and work with the other commission members. So just to wrap up, if the bill was amended to expand it and include more folks, we would support the bill.
Okay, thank you.
Thank you.
Now Representative Drew and then Representative Weber.
Thank you, Mr. Chair. So if someone is medically stable and they're no longer a danger to themselves or to the community, why doesn't NHH just release them?
There are some people that even though they are able to leave the hospital, they don't need the hospital level of care because they're not a danger to themselves or others. They don't need to be locked behind a door anymore. They might still need additional staff to help them take their medications on time or help get them to their appointments, help them process things if they're having difficulty processing something that comes up in their life emotionally. So that's why we have supported housing for folks, and we just don't have enough of it. So there are what they call level 5 people, and Ms. Bambonis could speak better to it than I can, but those are folks who really need additional support in their home in order to live productive, happy lives. I mean, it's not just about flailing about in the community, it's about trying to thrive in your community. And
follow up.
They need support in order to keep from going back to NHH. Would that be an accurate assessment?
not necessarily for everybody. Some of them might end up back at New Hampshire Hospital. Some of them might take their lives. Some of them could end up, simply homeless, but not a danger to themselves or others, and just not able to maintain their own apartment. So there's I think a wide array of things that could happen to individuals without the added support, one of which is potentially going back to New Hampshire Hospital.
Representative Weber.
Thank you, Mr. Chairman. Welcome back, and thank you for taking my question. If we were to amend this bill and broaden it in the way we've been talking about, should we also perhaps amend the title to better reflect the breadth of study that it sounds like we're contemplating?
I would suggest amending the title. I think it would be confusing if the title remained the same and then what followed underneath was something completely different. So I would recommend that.
Thank you so much.
Anyone else? Seeing no one else, thank you.
Thank you.
Also signed up to speak is Karen Rosenberg from Disability Rights Center of New Hampshire.
Good afternoon. I'm Karen Rosenberg. I'm the Policy Director at the Disability Rights Center of New Hampshire, which is the state's protection and advocacy system for people with disabilities. And I'm here to testify in opposition to this bill, although I was pleasantly surprised to hear that the committee is considering an amendment and that the bill sponsor is considering an amendment. As Ms. Mullen so clearly stated in her testimony, we don't need another institution in this state. What we need is more robust community-based services. And this is something that the Department of Health and Human Services, the hospital, the community mental health centers have been aware of for a long time. It's best for people who experience severe and persistent mental illness to be able to manage their symptoms at home where they can work and be in their communities. And it's also the law. So under a Supreme Court decision that was issued back around 1990, Olmstead is the name of this decision, the U.S. Supreme Court found that the Title II of the Americans with Disabilities Act requires that that states provide community-based options and not unnecessarily institutionalize people. If those community-based services can be delivered in a way that will address their symptoms, and that the person with the mental illness wants to be served in the community. And so back in, I think it was 2012, our office actually represented a class of individuals who sued the state for failing to comply with the requirements under Olmstead. And we ended up with a court-ordered agreement that the state is still working towards compliance on. But essentially, the input of the purpose of that agreement is to support the development of community-based services that would allow people who don't need to be at the hospital, such as the more than 100 on any given day who are ready to be discharged, to be served in the community. So if there was going to be a study commission to study this issue and look at how we could better support community-based services, that would be something our office would support. We would not support a bill that would continue to look at expanding institutional hospitalization level of care. We'd also suggest that individuals who experience mental illness are involved in such a commission because it's important that their views would also be reflected, people with lived experience. So thank you so much for your time, and I'm happy to take any questions.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So could you speak a little bit more about the current facility capacity? I'm looking into chart from previous testimony, and it looks like New Hampshire Hospital is typically close to 100% full. So what happens when some acute case or several cases arrive? Are some people who are ready to be discharged being kicked out, or is there some waiting list?
Well, I think this is probably a better question for the folks from New Hampshire Hospital who are here. I mean, my understanding is that if there's not a bed, they're not going to be able to fill it, and they've got over 100 people who are, or around 100 who are ready for discharge, and that would alleviate the issue that you're talking about. We do have other what's called designated receiving facilities around the state. Like you may have heard, like Concord Hospital has one, Cypress Center, some of the acute care hospitals have them that are also equipped to admit folks who are in a mental health crisis. But again, we really need more resources for those community-based services.
Anyone else? Representative Mazur.
Yes, thank you for taking my question. So this bill establishes a commission to study the possible need for and feasibility of reestablishing this. It's not a done deal. So what would be the harm in establishing a commission to really dig into this further?
Well, because I think what you've heard from the testimony that you've heard demonstrates that we have enough beds. We have enough inpatient psychiatric beds. And so it would be a shame and a waste of resources to have a commission set up to look at something where we already know the answer. And we already have devoted adequate resources. So, people's time is it's valuable. So I think focusing on where we know we have deficiencies in our service array would be just much more helpful.
Okay. Seeing no one else, thank you.
Thank you.
No one else has signed up to testify on HB 1372. Does anyone else wish to testify? If not, I'm going to close the public hearing on HB 1372. That is the last hearing we had scheduled for today. So we are going to end our public hearing schedule, and we are going to go into executive session on several noticed bills that we have up for consideration. Yeah. Okay, I think everyone is here. Representative Nagel will be filling in for Representative McKay, and Representative Nada will be filling in for Representative McLean. I'll give Representative Nagel a chance to get settled. The first bill to be considered, we have two early bills that we really need to get out right away. They need to go in next week's calendar, and I know the staff needs them as soon as we possibly can get them to them. So we'll start off with HB 1811 FN, and Representative Drew, did you have something to offer? I believe
Thank you,
have
Mr.
an
Chair.
amendment.
I have an amendment to offer, Amendment 2026-0644H.
Okay, and
2026-0644H.
okay, and Representative McGrath, did you want to
Yes,
second
I'd
that?
second that. Thank you.
Okay. Representative Drew, do you want to speak to your motion?
So this amendment is a compromise. Essentially, what we've done is we've reestablished the mandate list, but retained only polio in the mandate list. We removed the repeals of the mandate structure and the reporting structure. We made some minor changes to paragraph 3. And so it now says the Department of Health and Human Services may recommend vaccinations. And then at the bottom, it says the department and any political subdivision of the state of New Hampshire shall not require vaccinations under any circumstances other than as defined in paragraph 2. And finally, it adds a paragraph 3 under the exemption list, which extends. Is that right? No, that's not. Sorry, wrong paragraph 3. Where's the right? It amends RSA 141C20C by adding a third paragraph, a third exemption. A parent or legal guardian has a conscientious objection to immunization. The parent or legal guardian shall sign a statement that the child has not been immunized. Now, this provides a philosophical or conscientious objection exemption to the vaccine mandate.
Okay. Thank you. Other discussion? Representative Weber.
I will just state up front that I don't think we ought to be changing our current statutory requirements at all. And as such, I will be voting against the amendment and against the bill.
Thank you. Anyone else? Seeing no one else. Madam Clerk, if you're ready, please call the roll. Motion is ought to pass on amendment 0644H.
Representative Mazur,
Yes.
Representative Nodder,
Yes.
Representative Delanus, yes. Representative Copart,
Yes.
Representative Pelosi,
Yes.
Representative Drew,
Yes.
Representative Markel,
Yes.
Representative McGrath,
Yes.
Mayor Representative Kesselring,
Yes.
Representative Weber,
No.
Representative Nagel,
No.
Representative Woods,
No.
Representative Palmer,
No.
Representative Tejas,
No.
Representative Lamontagne,
No.
Representative Hartnett,
No.
Representative Lucas,
No.
and Representative McDonald.
Yes.
Ten to eight.
Okay.
Amendment motion to OTP passes.
Okay, Representative Drew, did you have another motion?
I would then move OTPA on HB 1811.
Okay, and Representative McGrath?
I'll second that.
Okay, thank you. Any other discussion, Representative Drew? Do you wish to speak to your motion further, or?
I think we've all heard more than enough argument on this one. Thank you.
Okay, all right, thank you. Anyone else have any discussion? Representative Lamontagne?
Well, I'm going to vote against this bill. I think it's extremely reckless. I think people already have the right not to vaccinate themselves or their children. But I think it's taking it too far to say we're going to eliminate these mandates or recommendations for everybody. It's going to just decrease our herd immunity. And I've heard people advocating for this bill that they don't believe in herd immunity. And I think that's such a generational amnesia of what we've accomplished by having universal vaccines. So I oppose this bill.
Thank you. Anyone else? Okay, if the clerk is ready, I'll ask her to call the roll. Motion is ought to pass as amended. I'm sorry, Representative Markel.
Thank you, Mr. Chairman. In assenting to this amendment, I think it's important to recognize a couple of things while we have had extensive discussion on it. Number one is that the amendment does recognize that polio is a very serious disease and recognizes that it's probably in the best interest of society to make sure that we are protected from a very serious disease. So I certainly commend the committee for recognizing that. Number two, when I look at the history of decisions on parental decision making and parental rights, I'm mindful of the fact that fit parents are presumed to be acting in the best interest of their children. So that is something which I take into consideration very importantly in supporting this amendment. But at the same time, I'm also mindful of the fact that the diseases that the original statute sought to deal with are still serious, are still important, and I respectfully commend parents and so forth to take real hard look at whether or not their children should be vaccinated. And in that spirit, I agree with the amendment. And I hope the committee can find some unity in that. And thank you.
Thank you. Representative Woods.
Thank you, Mr. Chair. I think we also have to keep in mind that taking it off means that is interpreted as not recommending. We're still keeping polio, that's fine. But just by virtue of taking the recommendation off tells the public that in fact we are not recommending. And that carries a lot of weight. I mean, you mentioned people dying of polio. A lot of kids are going to die because of not having other vaccines too. So I think we have to keep that in mind.
Representative Tejas and then Representative Drew.
Thank you. Just to add on to Representative Wood's comment, this is in all practicality, PCPs do not have an extra 5 minutes to talk to every single individual patient. This is going to gum up our already not very well functioning healthcare system for everybody. and huge unintended consequences.
Representative Drew.
Thank you, Mr. Chair. With respect to my colleague, I'll point out that this particular legislation is not a recommendation. This legislation, the current law has the force of law behind it. There is an exemption, but it is not a recommendation. It is a mandate. And this bill and the amendment have a specific charge to the Department of Health and Human Services that they can recommend vaccinations to everyone. So the only thing that this is changing is whether or not the vaccination is mandated. The recommendations are still going to be there. There should be, I don't foresee any confusion on the part of the public when the HHS continues to recommend the same vaccines at the same times. Thank you.
Thank you, Representative Mazer.
Yes, I'd like to keep in mind that we are not the first country to do this. There are other first world countries that have done this, and we haven't heard of any huge negative ramifications from that. So I am glad to support parental rights and this OTPA.
Representative Polazov.
Thank you, Mr. Chair. I think it's clear that parents are not allowed if there's a mandate. Mandate means that you have to do it. And if we are talking about that a lot of unvaccinated kids gonna die, we have to go back to testimonies about comparing groups of unvaccinated kids and vaccinated, and we saw testimony about 40% higher incidence of chronic disease in vaccinated kids, and then we had opposite testimony that prevalence of chronic disease in vaccinated kids can be ignored because it's explained somehow by different things, so statistically insignificant. What we did not hear a single study that showed that unvaccinated kids in US die in larger numbers. So if they are dying, it means that vaccinated kids die even on larger proportion. Otherwise, we had a study. So I think it's important to respect that science, and this amendment allow parents to follow the existing science. Thank you.
Representative Lamontagne.
Yes, the evidence that Representative Pelosi is referring to is what they're often quoted as the Henry Ford Center study, which was not published because it was found to be seriously flawed. That's why it wasn't published. So I don't consider that evidence, but we heard plenty of testimony from our public health professionals advising against repealing this mandate. Which, if parents are allowed to exempt themselves and their children, it's not really a mandate. So.
Okay. Representative Polazov, last comment.
We heard anecdotes that measles can cause deafness on one ear. We haven't heard a single study that showed that unvaccinated kids are deaf on a larger percentage. So absence of those studies show me that it doesn't exist.
Okay. Are we ready to vote? I don't know if you were waving to me, if you wanted to speak. All right, go ahead.
I'm sorry. It's been a long time. Thank you. I just feel I need to say this on behalf of the elderly people I just met with this morning, who every one of them experienced paralytic polio in their life in some way, shape, or form. I would like to thank you at the very least for putting polio back on the list, because they all lived through the horrors of that. So I would thank you for at least doing that. Thank you.
Thank you. All right, motion is ought to pass as amended on HB 1811 FN. Madam Clerk, please call the roll.
Representative Mazer.
Yes.
Representative Notter.
Yes.
Representative Delamus, yes. Representative Copal.
Yes.
Representative Palazzo.
Yes.
Representative Drew.
Yes.
Representative Markell.
Yes.
Representative McGrath. Yes. Representative Kesselring.
Yes.
Representative Weber.
No.
Representative Nagel.
No.
Representative Woods.
No.
Representative Palmer.
No.
Representative Tejas. No. Representative Lamonte.
No.
Representative Hartnett. Representative Lucas.
No.
And Representative McDonald.
Yes.
That is 10-8. OTPA passes.
Okay.
House Bill 1811.
Representative Weber, do we know who's doing the minority?
Representative Palmer is prepared the minority report,
Okay,
and it will be IPL.
okay.
So, excuse me, I'm sorry. Representative Weber, did you say you were going to be doing the minority?
No, Representative Palmer.
Oh, sorry, I'm sorry.
The staff, I'm
It
sorry.
will be inexpedient to legislate. for
Okay.
members. And
Okay.
Drew, you're.
It's already done.
Yeah, I
Yeah.
know, but just, I have to record it.
Sure. Representative Palmer, would you be able to get that done right away for the benefit of the staff? You have, okay. Okay, they're waiting for it, so yeah, the quicker you can get it done, the better. No pressure, no pressure. Okay, the other early bill we need to consider this afternoon, that we're under the gun for is HB 1784 FN. And Representative Drew, I believe you have a motion?
Yes, Mr. Chair. I move to interim study HB 1784.
Second.
And Representative Mazur seconds. Would you like to speak to your motion, Representative Drew?
Sure. The prime sponsor of this bill requested interim study, and so the committee is, I would assume, okay with that.
Okay, any other discussion? Representative Weber.
I would just note that the prime sponsor, when they spoke to us, noted a whole bunch of different considerations, and so I too think it's a fine thing for interim study.
Okay, great, thank you. Representative Mazur.
Just also quickly note from the prime sponsor that they did have a meeting this past Monday with the AG and all agreed that interim study would be preferable.
Anyone else? Representative Plazoff.
Thank you, Mr. Chair. I think it's very important to study this issue, but also consider why our state does this enforcement of legal medical mergers on larger extent than other states. And in my opinion, those Attorney General resources could be better spent. Thank you.
Thank you. Anyone else? Seeing no one? Madam Clerk, if you're ready. Motion is for interim study on HB 1784 FN.
Representative Mazur.
Yes.
Representative Nodder.
Yes.
Representative DeLamus, yes. Representative Kofal.
Yes.
Representative Palazzo.
Yes.
Representative Drew.
Yes.
Representative Markel.
Yes.
Representative McGrath.
Yes.
Representative Kesselring.
Yes.
Representative Weber.
Yes.
Representative Nagel. Representative Woods.
Yes.
Representative Palmer.
Yes.
Representative Tejas.
Yes.
Representative Lamonte.
Yes.
Representative Hartnett.
Yes.
Representative Lucas.
Yes.
And Representative McDonald.
Yes.
Okay, that is 18-0.
Is there any objection to consent? Okay. We do. Representative Drew has already done the report on that. Okay. Okay, next up is HB 1179. I will make a motion to ITL. Representative McGrath, I believe you have a motion also?
Second, thank you. What are we doing?
1179. And I know that this is a challenging issue and a matter of concern. At least I have not seen a fiscal note for this as yet. I'm not sure why exactly. But during testimony, among other things, we also heard that it was very restrictive in terms of the type of staff that would have to be hired. That wouldn't necessarily be the type of staff that was needed, but the type of staff that would be basically predetermined. So for a number of reasons, I am moving ITL. Any other discussion? Representative Weber.
Thank you, Mr. Chairman. I certainly agree that as written, this bill is not ready for prime time because we heard testimony on the one hand that it is not flexible enough to reflect the different levels of care and types of care that are found throughout the entire spectrum of our nursing homes. But we also heard very, very credible testimony that we have nursing homes that are failing to live up to what most of us would want for any of our friends, family members, or ourselves who need nursing home care. So I would prefer a motion of interim study as a real study because I think this deserves study. So I will not be voting for the inexpedient to legislate, but I do recognize that more work is needed and I'd like to have a forum to do the work.
Okay, thank you. Anyone else? Representative Hartnett.
Yeah, I couldn't agree more. I was very impressed by the nursing home leader, the nurse from Cheshire County, when she was she was opposed to the bill, but she gave us, I think, a wonderful bird's eye view into the challenges she faces trying to meet the psychiatric needs of her patients in relation to that bill. And she was just opposed to the specific bill, but she knows they need some help and support. So I think it does need interim study, and we need to look at minimum standards and classification for different types of nursing home endeavors. I mean, Representative Lucas asked in the last hearing a similar question around what is the nursing home capacity for psychiatric. We don't know, but yet we have nursing homes that are out there providing psychiatric care, and we have no way to really understand or regulate it.
Okay, thank you. Representative Woods.
Thank you. I think of all the comments I agree with as far as the interim study, and I think it fits very well with many of the bills we've heard has centered around the issue of workforce problems. And I think this would mesh very well and be a significant leg on which to stand in addressing what are the characteristics or mischaracteristics of our workforce. So in that sense, I would really vote for an interim study.
Okay, thank you. Anyone else? Representative Nagel.
Thank you, Mr. Chairman. I would echo what was just said. In my past life, I also was involved in overseeing the 8 nursing homes through the Catholic Charities. We actually saw star ratings of pretty much all our competitors within the state. So we saw broad variability. We're very proud of the job that our nursing homes did, but we saw that there wasn't quite as great a result in other places. I will also point out that our county nursing home person does not support this legislation, but I did not ask her about interim study, but it definitely needs way more work. I would say if you do an interim study, there needs to be strong stakeholder involvement in that process, because those are the people that live this every day and they know the subject the best.
Okay, thank you. Anyone else? Seeing no one, I will ask the clerk to call the roll. Motion is inexpedient to legislate on HB 1179.
Representative Mazer,
Yes.
Representative Nodder,
Yes.
Representative Delanis, yes. Representative Copal,
Yes.
Representative Palazzo,
Yes.
Representative Drew,
Yes.
Representative Markel,
Yes.
Representative McGrath,
Yes.
Representative Kesselring,
Yes.
Representative Weber,
No.
Representative Nagel, Representative Woods,
No.
Representative Palmer,
No.
Representative Tejas,
No.
Representative Lamontagne,
No.
Representative Hartnett,
No.
and Representative Lucas,
No.
and Representative McDonald.
Yes.
That is 11-7. I thought it was 11-7 to 8. It's 10 to 8. I thought I heard. I'm sorry.
Representative
Nagel, did you say yes?
He did say yes.
No. What?
He did say yes.
Oh.
Oh, I'm sorry. Then I misheard.
I'm voting for my chairman, my person.
I beg your pardon. I just misheard that.
That's okay.
That's
You
all
had me
right.
wondering
Doubt
for a
the
moment there too.
clerk. That's right.
I should not.
Okay, so is the minority motion I asked?
The minority motion is interim study, and I will write that for you. Mr. Chairman, may I ask, I assume that this is not going to go on the calendar for next week, so I could get it to you perhaps tomorrow.
Exactly, yeah. Other than HB 1811 and HB 1784, these others, if I can get them by the weekend, that'd be great.
Absolutely, thank you so much.
I will do the one for 1179, yeah, I'll be writing that one, as well as the one for 1782. Oh, okay, great, thank you. Okay, next up is HB 1562 FN, and Representative Mazer, I believe you have an amendment.
Yes. Yes, I would like to move amendment, I guess it's 2026-0415.
H, yeah.
H, yes.
Would you please repeat that? I'm sorry.
04, so it's 2026-0415H.
Yep. Thank you.
Okay, sorry, I'm also writing as we're doing this, so. So it's 1562 FN. Okay. And actually this, so we know Representative McLean, this is his bill, and I'm speaking to his amendment from him. So the first thing the amendment does is completely eliminate section 1 of the bill. So it does take nursing homes and rehabilitation facilities out of the bill entirely. We know that was a concern. Section 3, Roman numeral 2, further reinforces that the single payer model does not apply to nursing homes or rehab facilities. This language was reviewed by lawyers for the counties and addressed all their concerns, so the counties are now on board with the bill. In addition to this, as a nod to Representative Palmer, he inserted a repeal clause at the very end of the bill. The bill will take effect in January 2027 and sunset on January 2032. This is a safety valve in case a wave of cash-only facilities sweep the state. Further legislation will need to be filed in 2032 to make the provisions permanent. However, if by January 2032 repeal date, no facilities have sought licensure under the model, that will be taken as evidence that an all-cash wave is nothing more than a boogeyman, and the provisions will be made permanent without the need to file new legislation.
Okay. And Representative, oh yes, okay. Representative.
Yeah, I'm second.
Belozoff seconds, yes. Sorry. I was too busy trying to find that report. Okay. Any other discussion on this amendment? The motion is out to pass on amendment 0415H. Seeing no other discussion?
No.
Yeah. Oh, I'm sorry, Representative Weber.
Thank you. I'm of two minds about the amendment. I appreciate that there was some effort made to make things more palatable. I'm also well aware that there was considerable pushback, possibly not by people in this room, at the technique of voting for something to make it better and then voting against the amendment. I just find this whole concept of how to deal with healthcare very difficult to cope with. So I think I'm going to be voting no on the amendment, but I do recognize that it does move things in another direction. So I leave everybody up to what they would like to do with that.
Okay, anyone else? Representative Palmer.
I'm sorry that Representative McLean isn't here because I really do appreciate his efforts, and I'm going to vote for the amendment, but I'm still not sure what I'm going to do when we get past that.
Okay, thank you. Representative Woods.
No, thank you. I appreciate the efforts in trying to sort of shore up a difficulty that people recognize in the response. However, in 10 years, as far as I'm concerned, with private equity currently present and creating unbelievable disruption in our healthcare system beyond what it was already. In 10 years, the damage will have been done. So I cannot vote for the amendment.
Okay, thank you. Anyone else? Seeing no one else, I'll ask the clerk to call the roll. A motion is ought to pass on Amendment 2026-0415H.
Representative Mazer.
Yes.
Representative Nodder.
Yes.
Representative DeLemus. Yes. Representative Kofal.
Yes.
Representative Colazzo.
Yes.
Representative Brew.
Yes.
Representative Markel.
Yes.
Representative McGrath.
Yes.
Representative Kesselring.
Yes.
Representative Weber.
No.
Representative Nagel. No. Representative Woods.
No.
Representative Palmer.
Yes.
Representative Tejas.
Yes.
Representative Lamontagne.
No.
Representative Hartnett.
No.
Representative Lucas.
No.
And Representative McDonald.
Yes.
I was called McDonald.
I've been called a lot of things. Some can be repeated, some can't.
12 to 6, and the motion OTP passes.
Okay. I'm sorry?
On the amendment.
On the amendment,
On the
yes.
amendment,
On the
yes,
amendment.
I'm sorry.
Motion
I
of
should've
ought to
said
pass
that.
on the amendment passes,
Pardon
yes.
me.
Okay, next up, Representative Mazer, I believe you have another motion.
Yes. Thank you, Mr. Chair. I'd like to move OTPA on HB 1562-FN as amended.
And
I would like to
Representative
second.
Plaza seconds, yes. Do you wish to speak to your motion? Do you have anything further?
I don't have anything further. I think the, the amendment really fixed up the concerns, and I think this bill is great. So.
Okay. Any other discussion? Motion is ought to pass as amended on HB 1562 FN. Madam Clerk, whenever you're ready.
Representative Mazer.
Yes.
Representative Nodder.
Yes.
Representative DeLemus. Yes. Representative Kofal.
Yes.
Representative Colazzo.
Yes.
Representative Brew.
Yes.
Representative Markel.
Yes.
Representative McGrath.
Yes.
Representative Kesselring.
Yes.
Representative Weber.
No.
Representative Nagel. Representative Woods.
No.
Representative Palmer.
No.
Representative Tejas.
No.
Representative Lamontagne.
No.
Representative Hartnett. Representative Lucas.
No.
And Representative McDonald.
Yes.
Okay, that is 10 to 8. The motion of OTPA passes.
Okay, Representative Mazer, you will do the majority report? Okay. And Representative Weber, do you know who's doing that?
Representative Woods, might you be willing to do this one? Okay, thank you. It would be ITL.
Okay, that is 1562. Next up is HB 1734FN. And Representative Kesseling, I believe you have an amendment?
Yes, I do. I'd like to introduce 066H.
And I would like to second introduction.
And Representative Plazoff seconds. Representative Kesseling, do you wish to speak to your motion?
Yes, I would. So I want to first start off by thanking Rep. Lucas and Rep. Woods for working with me and going over some of the things that we needed to look at. And also after the hearing, I was able to take some of that information that they both gave me to put forward this amendment to make some changes so that we can make sure that the IRB was in focus. And then also Rep. Woods mentioned something with the pharmacy stuff and a bunch of conversations back and forth. So I just want to acknowledge that appreciation for that.
Sure. Okay. All right. Any other discussion?
Can you repeat the amendment number again, please?
It's a 0, it's right here.
Oh, the bad number.
Yeah, I know. If we'd started off with that, I would have been nervous, but.
Wait a minute. I had a bill number with that. Oh, bad.
I gotta have you repeat it one more time. 0 what?
666.
Oh.
H.
Easy. Okay.
Yes.
You have to say it is kind of interesting that we're doing a bill for experimental treatments for people that are about to die with that number. So.
Oh.
Well, it is a
that's so
666 for them,
nice.
that's for sure. Okay. Any other discussion on this amendment? Okay, one final time. Motion is ought to pass on 2026-0666H. And Madam Clerk, when you're ready. Sure. Sure.
This is 1734.
Yes. Amendment.
Representative Mazer.
Yes.
Representative Nodder.
Yes.
Representative Delamus, yes. Representative Copel.
Yes.
Representative Palazzo.
Yes.
Representative Drew.
Yes.
Representative Markel.
Yes.
Representative McGrath.
Yes.
Representative Kesselring.
Yes.
Representative Weber.
Yes.
Representative Nagel. Representative Woods.
Yes.
Representative Palmer.
Yes.
Representative Tellez.
Yes.
Representative Lamonte.
Yes.
Representative Hartnett. Representative Lucas.
Yes.
And Representative McDonald.
Yes.
Looks like 17-1.
Okay. Well, it's just an amendment. We gotta go to the main bill first. Okay, great.
Okay, I've got to make sure I find
Representative Kesselring, do you have another motion
I would like to motion that ought to pass as amended.
on HB 1734FN? And Representative Palazzo?
I'm seconding.
Thank you. And any discussion on the motion? Any further comments?
I think we're good.
Representative,
I think I'm good with any further comment.
okay. Representative Woods, did you have your hand up? Or?
Thank you, and I would like to thank the representative for developing what I think is long overdue. And medicine, I can throw rocks since I'm in the medical community. I can throw rocks legitimately. This is long overdue. However, Representative Kesselring was very attentive to my suggestions. There's some intricacies relative to reporting and so forth, and et cetera. And I think those were taken into account. And that's the way we should be working. However, as I've already indicated, I will vote against the bill itself because, again, I'm harping on that problem that we have nationally, and that's private equity. Private equity is not sufficiently controlled in this particular bill. The thread is good, the thought is good, many of the details have been sorted out, but it's still it is heavily weighted for private equity, and it's, as I said, our healthcare system is really so fragmented, and this would even potentially fragment it further. Again, I thank the representative for what he's done so far, but I'm going to have to vote against the bill.
Thank you, Representative Weber.
Thank you very much, Mr. Chairman. And I would like to go farther with that in that, first of all, it breaks my heart to vote against a bill that is intended to help people who are afflicted with either Parkinson's or Alzheimer's disease, because I have family members with both. However, I find that the way this bill is structured is potentially absolutely devastating to patients. And I think that in many cases it also offers false hope. And I think that the idea of New Hampshire becoming, I think the quote was, and I hope somebody will forgive me if I've misquoted, but the wild, wild west of risk, of allowing risk taking, is simply not a place that I think New Hampshire ought to be. And the idea of treating, of having patients be experimental subjects and having to pay to be experimental subjects is also not a place I want New Hampshire to be. So I will be voting no.
Anyone else? Representative Lucas.
Yeah, I just wanted to add that I really appreciated working with Rep. Kesselring on the amendment issues. But I also join Representative Woods. I think medical entrepreneurialism tests the bounds of medical ethics. And just speaking for myself, I cannot vote in favor of that.
Representative Mazur.
We live in the live free or die state. So I think New Hampshire is perfectly poised for this bill, and especially we passed right to try last year. This is a perfect sequel from that bill. So I am really proud to vote for this.
Anyone else? Seeing no one, I'll ask the clerk to call the roll. Motion is ought to pass as amended on HB 1734 FN.
Representative Mazur,
Yes.
Representative Nodder,
Yes.
Representative Delamus, yes. Representative Copal.
Yes.
Representative Palazzo.
Yes.
Representative Drew.
Yes.
Representative Markel.
Yes.
Representative McGrath.
Yes.
Representative Kesselring.
Yes.
Representative Weber.
No.
Representative Nagel. No. Representative Woods.
No.
Representative Palmer.
No.
Representative Tejas.
No.
Representative Lamonte.
No.
Representative Hartnett. Representative Lucas.
No.
And Representative McDonald.
Yes.
That is another 10 to 8.
Okay.
Motion passes.
Representative Kesselring, you'll do the majority report on that one? Okay. And do we know about the minority representative?
Representative Lucas will be the minority. That will be ITL.
Okay. Okay, one more. Next up is HB 1735, and I don't think there are any amendments to that one. Okay, Representative Kesselring, do you have a motion?
I move ought to pass.
Okay, and Representative Mazur, I believe.
I wholeheartedly second.
Okay. Representative Kesselring, do you wish to speak to your motion?
Yes, thank you, Mr. Chair. Although I do feel that Representative Mazur might be better at this because she's already done this once, but the expansion of right to try is something that I think is important based on where we're going from the conversations that we've had. Whether this bill in its entirety makes it through the other side of the wall, I do think it's a conversation we need to have to be able to fix some of what we didn't fix last year. So with that being said, that's why I put it forward, or why I'm making this motion, and I'm excited to see this move forward.
Okay, any other discussion? Representative Weber.
I'm just concerned that we are going a little too far with this and removing some of the guardrails that we've already had in place. And therefore I will be voting no.
Okay, thank you. Anyone else? Seeing none, I'll ask the clerk to call the roll. Motion is ought to pass on HB 1735 FN.
Representative Mazur.
Yes.
Representative Nodder.
Yes.
Representative Delamus, yes. Representative Copal.
Yes.
Representative Palazzo.
Yes.
Representative Drew.
Yes.
Representative Markel.
Yes.
Representative McGrath.
Yes.
Representative Kesselring.
Yes.
Representative Weber.
No.
Representative Nagel. No. Representative Woods.
No.
Representative Palmer.
No.
Representative Tejas.
No.
Representative Lamonte.
No.
Representative Hartnett. No. Representative Lucas.
No.
And Representative McDonald.
Yes. Yes.
10 to 8. Motion passes.
Okay. Representative Kesselring, you'll also do the majority
Attorney,
report on that?
Were you going to do this one? I don't care which one of you it is, but I need a name for the people who need to give it to House Committee Services. Do you want to do it? Yeah. So you get two. Lucky you. Thank you very much. Appreciate it.
And the motion will be ITL?
That will be an ITL, and it will be Representative Lucas, and we'll all be glad to help.
Okay, and unless I've missed something, that concludes all of the That concludes all of the bills that were noticed for today, in addition to
And one
HB 1782 FN, which we previously voted on. Does anyone else have anything for the committee before I adjourn? We, again, we're going to be meeting next Wednesday, our usual schedule. The bills will be noticed, and then executive session will be noticed. There will be no house session next Wednesday, only on Thursday. So I think it'll be business as usual. And with that, we stand adjourned.
Majority of them, they said, no,